I believe we should be good.
Okay. So item number 10, welcome back to the Joint Labor, Health and Social Services Committee meeting. Item number 10 is several reports from Department of Health. The first bullet point does say report on agency budget reductions. Based on what the governor's office said, they may not have anything to say, but Department of Health, feel free to work your way down the bullet points on your agenda part. And there they are.
Yes, Chairman Wilson, it's Mike Sabias, committee.
Director.
I wanted to again just reiterate the comment that you've already made about the budget reductions. We don't have more to share with you. I would tell you that just as Erica shared, we do know generally what we're going in. We're just trying to wait for the final pieces, but we are preparing to implement it. So I think when we do get the notification that we're set, we'll be able to do our work. We've talked with our different divisions. They're ready to move forward with it. But again, we are waiting for the governor's thumbs up.
All right, well, we appreciate that you don't want to be the source of leaks. So I believe the next item then is update on the progress at the State Hospital and the Life Resource Center. And thank you all for the invitation to the ribbon cutting, although probably most of us are not planning to drive all the way to Evanston. I suppose Senator Schuler might be there if to carry out our involvement, but okay, Stefan, if it's you, go ahead.
There.
Thank you.
Thank you, Madam Chairman and members of the committee. Stefan Johansson, Deputy Director for the Wyoming Department of Health. Real quick on the agenda here, we've glazed over the budget reduction update, so I'll provide you some brief updates on 3 items you asked us to present on. One, the progress at the State Hospital and the Life Resource Center, progress on the 2020 House Bill 31 and our partnership with Department of Corrections, and finally a CARES Act funding update. With the money from the $1.25 billion in the state government CARES Act pool that has been allocated to the department, we'll just provide a little bit more detail and answer any questions, kind of expanding on what Erica Legursky and Jen Davis presented earlier. So with that, we'll jump right into an update on the 2 facility projects. As you mentioned, Madam Chairman, we are excited that on August 28th, we will be doing a ribbon cutting ceremony. Unfortunately, due to the times that we're living in with COVID-19, it's a bit of a smaller or more modest celebration and ribbon cutting ceremony than we would have intended, but still meaningful nonetheless. So we've invited several key dignitaries, as well as Madam Chairman, yourself, and Chairman Scott. We understand that, especially given the time that we're in, not everybody will be able to make the trip to Evanston. So accordingly, we are working with Wyoming PBS is going to send a crew out to Evanston to at least videotape the event, maybe take some interviews and some photography and video inside the campus before it's occupied with staff and patients. And we're working right now to see if we can live stream that. There's a few, since it's an outdoor event, there's some internet connectivity issues that we're working through, but wanted to let the committee know that I'm 99% sure you'll be able to see as much of the event maybe after the fact as possible. So that's very exciting, and we're just really happy to be able to celebrate something, especially in this interesting year that we've had. It's nice to bring a project to near completion that we think is really going to be an improvement for service delivery and behavioral health statewide. So like I mentioned, this is what August 28th and into September is really what we're referring to as phase 2, substantial completion. The reason I mention those terms is that we will have work at the facility that will be ongoing into the fall and potentially into the winter, but it doesn't have any impact on patient or staff occupancy of the new campus. It's really some further renovations to the administrative areas that were always part of the plan. So the ribbon cutting will really celebrate our ability in the month of September and going forward to start moving patients and staff into the new campus. The new staffing plan that was approved by the legislature in 2020, as a gentle reminder, we worked with you all, with the Joint Appropriations Committee and ultimately the legislature, to identify positions and internal funding from the previous biennium in the Department of Health to be able to finance our needed staffing at the new facility. And again, to be able to bring on additional bed capacity as was the plan, as well as long-term, if we can nail this mission, be able to save money in Title 25 going into the 23-24 biennium, as well as save money at the Life Resource Center and the state hospital with outside contracts for contracted labor that you pay a premium for. Won't go into the details of that plan right now in the interest of time, but the department really has committed to execute that mission by using internal funding, essentially promising that we can sustainably finance the new facility staffing plan with budget savings in the future, again, from Title 25, from outside medical expenses, contracted labor, et cetera. So that's, again, a very exciting time for the state hospital. We're working on the staffing plan right now. In fact, as of last week, the reports I had was that we had no CNA vacancies, and we are bringing on additional CNA positions per the approved staffing plan as we speak. In addition, our nursing staff levels for the past 6 months have looked very good. We did reach a point in the early spring that we had no nurse vacancies at the state hospital either. That's the first time in my tenure with the department that we've seen staffing levels that stable at the state hospital in Evanston. And in addition, our retention rate and our key direct care staff, including our nurses and our CNAs, has dramatically improved over the past 12 to 18 months for a variety of reasons and due to some measures that we put in place to really encourage retention. So I say all that to indicate we have gotten a lot of pushback, and rightly so, that with the new facility and the new staffing plan, basically hearing from stakeholders, will the department be able to staff this? Everybody knows it's a challenge to recruit professionals in behavioral health in Evanston, in basically all of the areas, the towns that we have Department of Health facilities. But this is a good kind of optimistic indication that we're moving in the right direction. Just provide you a couple of aerial shots. These are from a couple of months ago, so apologies for a little bit of dated photography, but you can really see here the campus, at least in the buildings, kind of completed in full in Evanston. You can see the building, traditional building with the large blue roof or green roof that everybody knows from the highway driving through Evanston. That's what I mentioned before, that will have additional renovations going into the fall and winter of this year, where that roof will essentially come down. It will mimic the look and feel of the rest of the campus. And that's kind of the phase 3, the last phase of the project. Again, just another aerial shot here. All of that landscaping that you see there on the western and northern ends of the campus, it does not look like that today. So for those of you who might attend the ribbon cutting ceremony, I think you'll be pleasantly surprised with the look and feel of the new campus. Moving on, Madam Chairman, to the Wyoming Life Resource Center. Again, it's important to note that these two facilities were remissioned and repurposed kind of together as one facility with long streets per the facilities task force and the legislative authorization for these new projects. So these facilities will work in tandem, and we've already had several successful transitions from the state hospital to the Life Resource Center, even before the new campus, the new physical plant at the Life Resource Center is complete. So we're moving in a good direction there. In terms of the actual progress on the construction project, our recreational center, what we call the rec center building, that was completed several weeks ago. That's essentially the areas where clients can exercise, have aquatic therapies, et cetera. It's a wonderful building, and we're very excited to be occupying it right now. It has been in use for, I believe, about the last 5 or 6 weeks. In addition, multiple program buildings and cottages are either complete or nearing completion. And there's been ongoing discussions with other agencies and other entities in the state for repurposing of Life Resource Center space. I know that there's several tangential conversations going on about space, not only the Life Resource Center, but elsewhere for use with other populations, potential adolescent populations, and those conversations are ongoing. In addition, we do have space on that large campus in Lander that other agencies were interested in, also for administrative purposes. So we are looking to, make the project in the campus as efficient as possible. Substantial completion, Madam Chairman, for the Life Resource Center is scheduled for the spring of 2021. As you all know from our last update, this was originally in the plan scheduled for completion in December of this year in 2020, but due to some significant discovery of asbestos containing material and a large mitigation effort that had to take place, it did get kicked back about 4 months or so. And we've worked through those issues with construction management department as well as the contractors on site. So we are right now, again, a knock on wood, keep your fingers crossed. We are planning for a substantial completion and occupancy of the entire campus in the spring of 2021. Just a few pictures here. The top left that you can see there is the recreational center, a part of the recreational center that I mentioned, with a very nice pool that's already getting a lot of utility and has been very well received by the staff and the clients. You can see the gymnasium in the same building right below that, as well as some less complete areas, but foundation work that's been ongoing over this past summer. In addition, you can see an almost completed cottage here on the campus, cottage and program buildings, and a nearly completed cottage on the bottom photo there. You can see some flooring when this picture was taken was still being ready to be installed. But I wanted to point out that photo on the bottom because for those of you who were either part of the facilities task force or following it or part of the discussions during this development with Joint Labor and Health, you'll remember that this was designed around the greenhouse concept of care, similar to kind of the physical layout that you would see at the greenhouse nursing home in Sheridan. And so the cottages for the residents that you'll see here are laid out in that greenhouse model where you have kind of a central kitchen, central living area, and then rooms kind of adjacent, private rooms adjacent to that. Madam Chairman, I will stop there with the facilities update, the construction update, and see if the committee has any questions before we move on to House Bill 31.
Questions for Mr. Johansson on the facilities? Senator Schuler.
Thank you, Madam Chair. Just wanted to mention that I really think that the state hospitals it's turned out really nice. Appreciate all the tours and all the updates that have been given along the way. I think the people that work there, I've talked to a lot of them, are really excited to get in there, and I'm sure the clients are as well. And so I'm looking forward to the ribbon cutting. Just wanted to keep it on your radar. There's still lots of questions in our community about what will happen with the old one. Are they going to be repurposing anything at all? Is there money for, potential, I mean, I guess, worst comes to worst, they may have to demolish some of it, but just kind of want to keep it on your radar. I know that's not the priority right now. And I know with budget cuts, it may be put on hold for some time, but I just want to keep it on the radar of our Department of Health and as well as our committee. Thank you.
Again, committee, because the PowerPoint is still up, I can't see your physical hand, so feel free to use the blue hand if you have something to ask about. Well, Representative Sweeney.
Thank you, Madam Chairman. My question is in regards to the state hospital. On anybody that the court system sends down for evaluation down to the state hospital. So have we in the old building, there was an area that was kind of set up for an secured outdoor yard, that type of thing. Do we have that in the new facility? Didn't really notice it when we were down there last fall. Or are we still repurposing that part of the old campus to utilize on that population?
Madam Chairman.
Mr. Johansson.
Thank you, Madam Chairman. Representative Sweeney, a good question. At the time that you all were there last year, you wouldn't have been able to see the forensic courtyard, essentially is what we call it, on the new campus. So the simple answer to your question, sir, is yes, that will be part of the new campus, not needing to repurpose anything from the old campus. I'm happy to send you some photographs and some aerial shots of what that looks like, but there are multiple interior courtyards, and on the criminal justice services part of the campus, there is a large outdoor space with a security kind of anti-climb fence that's part of that campus. So absolutely, sir.
Okay, thank you. And one other follow-up question, if I could, Madam Chairman.
Representative Sweeney.
Thank you, Madam Chairman. So back to Senator Schuler's comments on repurposing. Is there any, the last information, I don't believe there's actually any money left for repurposing any of the old money or tearing them down. Is that correct, or will that be under the state building commission's preview is in the next step?
Madam Chairman.
Mr. Johansson.
Thank you, Madam Chairman. Representative Sweeney, let me double check on the status of the demolition budget for the state hospital. It was requested in the last budget as just kind of a placeholder while those discussions, especially in the Uinta County community, were ongoing of their interest in repurposing space. We did request, and when I say we, I actually mean the construction management department, requested $10 million reserves for capital construction related to building demolition. I believe the CapCon bill broke down at the end of the session, so I need to double check where that money is, if it's there at all. But Representative Sweeney, I'll have to follow up on that.
Madam Chairman.
Representative Sweeney.
I'd appreciate that, and I don't quite honestly, I don't like to use the word demolition when it comes to that site, but repurposing, utilizing some of that demolition money, I think would be a great thing for the community, and possibly Senator Schuler's got a great idea with the nursing program that I've brought up during state building commission meetings with the community colleges, but I haven't got a whole lot of traction, quite honestly. So, but we'll keep trying.
Representative Hallinan.
Thank you, Madam Chairman. This is on a slightly different topic, but during the last session, Representative Pepperinen brought up to me and shared with me newspaper articles about beatings and dangerous conditions that existed at the state hospital. I was wondering, do you have any information on that, on the case of the individuals that were assaulted or beaten there, or do you think that has been addressed by the administration there?
Mr. Johansson.
Thank you, Madam Chairman. Representative Hallinan, that's a good question. I won't go into the specifics of those actual cases, but you're absolutely right that there was articles, I believe, late last year from Evanston, Uinta County Herald, I believe, noting some patient on staff aggression and violence that had happened over the years. It is absolutely true that with the population we deal with there, it is a dangerous place to work in many cases, but also a rewarding place to work. We do everything we can, Representative, to ensure our staff safety and also ensure the civil rights of the patients that are there. So we try to strike a delicate balance between the security that we're able to and need to have on the campus with the clinical and therapeutic environment that's intended at a psychiatric hospital like this. But no doubt about it, I can't candy coat that we do have clients and residents at the state hospital that have significant behaviors, exceptionally difficult behaviors and violent behaviors that we try to mitigate as best as possible from a therapeutic perspective. Over the years, we have added staff, both in terms of being able to leverage additional staff to client ratios when necessary. So think of your one-to-ones, your two-on-ones, and especially on the forensic unit, adding additional security personnel to be able to more quickly respond to aggression and things of that nature. The last thing I'll mention, Representative Hallinan, is I am very optimistic with the new physical plant that while our treatment of patients with really significant behaviors, violence issues, et cetera, will never go away with a facility like this. The physical plant itself, the improvements that we've made, I believe will foster an environment of that will be much safer. When you think of our patient rooms that will all be single occupancy, the physical layout of the building being much more centralized, much more easy to manage and staff than the very spread out campus we have now. We've taken a number of measures, both on the physical plant side and on the staffing side, to ensure that we can mitigate those issues as much as possible. But certainly something at a hospital like this that we will continue to be challenged with and continue to confront.
Thank you, Mr. Johansson. Senator Co-Chairman Scott.
Madam Chairman, my question relates to the Lander facility and situation once it is completed this spring. What I want to know is what kind of capacity do we have there to accommodate if we get a sudden rush of new cases that need to be in Lander. What do we have any capacity there to accommodate them? And what's specifically triggering my concern, Madam Chairman, is I don't think there's any problems with the current set of providers right now, none that I'm aware of, but I'm afraid if we get something wrong in the budget cutting process in the next 6 months and we lose a provider, do we have any capability in Lander to accommodate severe clients temporarily while we get that sorted out? Because I think that when you get into the magnitude of the budget cutting, we're going to have to. I think there's a risk that something will go wrong there and we will lose a provider. As I say, I don't know of any specifics right now, but I want to know what are our backstop capabilities at Lander once that's complete.
Mr. Johansson.
Thank you, Madam Chairman and Co-Chairman Scott. A good question. First and foremost, in terms of the capacity, we are greatly expanding the capacity with the new facility at the Life Resource Center, going to 110 beds across the campus. So that's a pretty large expansion for the campus as it sits right now. In terms of the ability to admit populations if we have a surge, not to paraphrase you, but that's kind of how I heard your question. We will have that expanded capacity, assuming that the clients that are being admitted would meet the statutory definitions that have been set up for the facility. So, the clients that are statutorily authorized to be admitted to the Lander facility are the legacy population that's there now, clients who have developmental disabilities and manifest exceptionally difficult behaviors, clients with high medical needs who are hard to place. So there's some specific criteria in the Life Resource Center statute, and we have an admissions and an application process to do that. So I do think we would have some ability to take on additional clients if they meet those definitions. To a kind of a tangent, sir, if I may, the discussion that's been ongoing that I mentioned before is we do deal with that, as you know, with a small amount of cases on the adolescent side and really exceptionally difficult clients, both with medical comorbidities, behavioral issues, medical issues, et cetera. That we are able to do emergency placements with the director's authority at any of our facilities, including the Life Resource Center, but we are authorized to do that on a temporary basis. So again, it's kind of a mixed bag, sir, but we will have a expanded capacity and footprint at the Life Resource Center to potentially deal with some of those issues if they play out the way that you described.
Any more questions? Representative Sweeney.
Thank you, Madam Chairman. At the Life Resource Center, when we took the tour, I can't remember when that was, but there were some clients that had been moved from the state hospital into what I would call housing units, like smaller pods, and for a different treatment to be reintegrated back into their home community. Are those buildings still on the schedule for demolition, or would we be able to hang on to those for possible later use that might be appropriate down the line?
Madam thank you, Madam Chairman. Representative Sweeney, the short answer is frustratingly yes and no. The buildings are slated as part of the project to come down. But as I mentioned, conversations have been ongoing for the better part of this last year about repurposing. What I would mention there is the Life Resource Center as it stands right now is not missioned and is not legislatively authorized to, for example, admit and treat adolescents. Like I mentioned to Senator Scott, we have done that on occasion on an emergency basis when there's really nowhere else to place a client that really does meet those kind of Olmstead and statutory criteria for the facility. So the longer answer, sir, is that I think those conversations can continue. I would make a humble request from the legislative perspective that if the desire is to expand the mission of the Life Resource Center, that be kind of done in a thoughtful manner, similar to what happened with the facilities task force for the new missions of the state hospital and the Life Resource Center, so that we don't get into a situation where the department is either perceived to or being indirectly requested to, admit clients that aren't necessarily part of its mission.
Follow up, man.
So,
would the department see that if it came to it, would those pods be acceptable for adolescent treatment, or not, if that was so desired?
Madam Chairman and Representative Sweeney, there's a number of issues there. I think in terms of the physical structure, my short answer would be yes. They're nice buildings. They're designed in a greenhouse model. The issue is really with the wider campus. When you start talking about adolescent care on a facility or institution like the Life Resource Center, it depends on the licensure, what you're providing, what level of care you're providing, and how you have to segregate the campus. So a good kind of analogy there is with WBI and Casper, who treats both adult psychiatric clients as well as adolescents on psychiatric hospital and PRTF level of care. There's very strict regulatory criteria for how that campus has to be essentially segregated for the purpose of adolescent treatment. So it's certainly something that could be explored. But I did want to mention, Representative Sweeney, to your second point in your question, the state hospital, when you toured and since then, the state hospital and Life Resource Center have worked together to transition several clients as part of the mission from the state hospital, acute stabilization to short-term and intermediate care with ultimate goal of discharge to the community using the Life Resource Center. We've had some very good success in the past year doing that. Still a lot to learn, still a lot to improve on with that new mission, but we've had some successful transitions and even a transition out into the community per this new mission. So from my perspective, humbly, that's going very well. But again, those conversations about additional mission, additional services or clientele that the Life Resource Center could serve, or repurposing for the state hospital, those conversations can still be ongoing. There's no plan in the immediate term, next month to start bringing down buildings on either campus.
Okay. Any more questions? All right, thank you. Looks like we have, are you going to continue on first, Mr. Johansson, or are we going to switch over to welcome new director, Shannon?
Madam Chairman, totally up to you. We have a similar update that we provided to the Mental Health and Substance Abuse Subcommittee on the House Bill 31 progress. So for some of you, I believe, who serve on that subcommittee, this might be a bit redundant, but happy to bring on Director Shannon to correct anything that I might misstate, especially on the correction side.
Well, we'll let both of you run through it as however seems best to you.
Thank you, Madam Chairman. I'll go ahead and start. I'm not sure if Director Shannon is in the room, but in terms of House Bill 31, just as a reminder, the legislature passed that bill in the most recent session, really directing, it's kind of a mixed bag of items that the legislature directed the two departments to work on. I'll take a few of them at a time. The first kind of portion of the bill was really directing kind of a prioritization of corrections clients in the community mental health and substance abuse system. So what I show the committee on the screen right now is the additional contract language for the community mental health and substance abuse centers that has been added to the current fiscal year contracts for what we're calling targeted populations. And this means for substance use disorder treatment, and you see the two definitions there. Basically, to paraphrase, people who are on probation and people who are on parole being a targeted population for the community mental health and substance abuse system. And if Director Shannon is on, I will certainly kick this part over to him, but if he's not on, I'm happy to give you the quick version.
Madam Co-Chair,
Director Shannon.
Madam Co-Chair, Chairman Scott, committee members, I'm Dan Shannon with the Department of Corrections. I'll just have a brief follow-up on Deputy Johansson's regarding Justice Readvancement Sub-Award. I can report to the committee that the sub-award has been submitted. CSG is now through the Bureau of Justice, and the CSG is waiting for the official support, but they would anticipate within the next 30 days that we would receive that funding. That funding is in the amount of $126,983. That funding is also could be utilized through March 31st of 2021. Now, what are we going to get for that funding? There's 4 specific items that we outlined, and I would like to just provide the committee just a brief update of where that money would be spent. One is for a quality assurance unit. That information would be provided. The individuals are to be hired by October 2020. For the month of November 2020, we have 2 points that we want to accomplish. One is to create for the Department of Health as well as the Department of Correction to complete their leadership team training. This would be virtual training, as well as training for theoretical foundations for our ASAM criteria to ensure unanimity amongst our testing. And last but not least, the consistency of treatment practices, which I believe was the major goal here. This training should occur by January 2021, Madam Chair.
Questions for Director Shannon? Remember the blue hand if necessary. Okay. Is there more on this, or is that it?
Okay. Madam Chairman, I'll ask.
Oh, okay.
I'll ask Franz to go to slide 26 just to close out this presentation, and certainly let Director Shannon comment additionally if he would like to. Just wanted to point out again some of the process that's ongoing that again was part of the direction from the bill for the 2 departments. Really the spirit of it was to work together to target some of these clientele. So what you see on slide 26 is just some of the collaboration that's been happening over the past 4 or 5 months or so. Next slide, Franz. On slide 27, in terms of just to be realistic, some of the implementation challenges related to House Bill 31, there are some data privacy and sharing concerns that are being worked through. In addition, I did want to mention the last bullet point here. Both agencies have been significantly sidetracked with managing the COVID-19 pandemic. That has slowed the development of what was called in the bill the competitive and outcomes-based funding program to essentially change the payment model in the community mental health and substance abuse system for these clients. We do plan to continue to work on that, but just to be forthright and honest with the committee, the COVID-19 pandemic management has taken a front seat to some of that work. But I am proud of the Department of Health and Department of Corrections staff on some of the other items that we just mentioned, including grant awards and some of the more process-based measures have been ongoing over the past 4 or 5 months. Thank you, Madam Chairman. Happy to answer any questions or move on to the CARES Act funding.
More questions on House Bill 31? I don't see it. Oh, Representative Sweeney.
Thank you, Madam Chairman. To Director Shannon, first off, congratulations. But on the quality assurance unit, my question is how does that, I mean, you were already monitoring within the prison system and Department of Corrections what goes on inside, but is there a broader scope now that the quality assurance unit will take on?
Madam Chair, Representative Sweeney.
Director Shannon.
Madam Chair, Representative Sweeney. Absolutely, sir. The quality assurance is more an external for the entire state as much as possible. With the funding that's available, we anticipate hiring 2 quality assurance individuals. And more importantly, as Deputy Johansson spoke of, getting us all on the same page in the spirit of cooperation. If we can consistently grade our treatment practices on one level plane, that'll really show us where we're at and where we need to work. So to answer your question, Representative, it's for external as you would anticipate, and that is our intention to our treatment providers.
Thank you.
Great. Thanks very much. Glad to, we are certainly aware that the COVID situation has taken over vast parts of your brains. If I can only compare to what it's done to my brain, and that's such a minimal workload compared to yours. So we appreciate your ability to carry on as best you can with all these things. Okay, let's see. Drug importation, I believe, is the next one, which is another one where I'm not surprised that COVID hasn't taken over a bit of this. Also kind of informed us in an interesting way about supply chain issues. So go ahead, Stefan.
Madam Chairman, happy to kick that over to Franz. We were asked for a CARES Act funding update.
Oh, sorry, wrong one. Yep, go ahead.
So just very quickly, Madam Chairman and members of the committee, on slide 28, you'll see a breakdown similar to what you saw this morning from the governor's office on CARES Act funding, specifically from the 1.25 billion pot that's in the state government CARES Act pool, what has been allocated to the Department of Health. And don't have to go into these in great detail unless there's questions, but as the governor's office had mentioned, this has really been money that we've been actively spending to expand our capacity to process COVID-19 samples and tests at the Wyoming Public Health Lab, as well as bring on additional third-party contracts to do both diagnostic and surveillance testing for COVID-19. So you see it broken out here on a couple of several high-level categories, but the total amount that we have obligated as a Department of Health since we received or have been receiving our allocations from the governor's office is about 38.5 million across these different domains. Our total allocation right now from the governor's office is about $60 million with, as I understand it, an additional 40 million kind of earmarked for Department of Health efforts through the duration of the CARES Act funding and the COVID-19 pandemic. Before I answer any questions about these particular funds from the state government allotment, I did want to mention to the committee that as was discussed earlier this morning, there are a lot of CARES Act funding sources out there that are not part of that $1.25 billion. So for example, Health and Human Services has allocated money through various sub-agencies to entities like our divisions in the Department of Health. So for example, our aging division has received about $5 million from the CARES Act, again, not the 1.25 billion, but the CARES Act for through the Administration on Community Living, which is the kind of our Older Americans Act federal regulation entity, which has been passed on to the senior centers for COVID-19 related expenses, and to be able to continue their Title III programs, for example. Earlier this morning, Meals on Wheels was mentioned. That could certainly be part of that kind of subsidy that's coming through a different pot. In addition, you're all aware of the Health and Human Services Provider Relief Fund, which is another arm of the CARES Act that has been basically deposited directly into the accounts of healthcare providers like hospitals, clinics, even some mental health and substance abuse providers. So just wanted to be clear, Madam Chairman, that what we're showing here is really the CARES Act funding from that 1.25 billion. But we're more than happy, even though it changes on a daily basis, to provide a general summary to the committee of at least what we're aware of in CARES Act funding that has been sent to the department through various sources outside of that state government allocation. Happy to answer any questions from the committee on what's on the table here, Madam Chairman.
Questions for Mr. Johansson? Representative Sweeney.
Thank you, Madam Chairman. So I've had some comments by the medical community here in Casper on the public health laboratory. Is there any, currently, have they been affected by budget cuts or the furloughing of 1 day a month in getting tests turned around? What I've been told is all of a sudden we're seeing a lag in results. And so I wondered what kind of response is at this point on the public health on the lab?
Madam Chairman, Representative Sweeney, good question. I'll take it kind of in pieces. As far as I know, and I will double check as of today, our turnaround time at the Wyoming Public Health Laboratory upon receipt of a sample is 24 to 48 hours. So it is still quite fast for a sample turnaround time there. In terms of your comments on budget cuts and furloughing, we do not have any substantial planned cuts for the Wyoming Public Health Lab, especially during the pandemic, and in fact have been leveraging, as you see here, quite a bit of federal funds to expand capacity at the Public Health Lab. And that's both in terms of supplies as well as human capital. We have repurposed temporary positions that were already authorized for the department to be able to bring on additional workflow support at the Public Health Lab. And to your second point, in terms of the furloughs, the Department of Health, for the staff that did qualify for the furloughs, we are all complying with the 1 day a month furlough between August and January. But we have worked between the Public Health Lab and all 5 of our direct care facilities to ensure that for the staff that met that criteria and must furlough per the direction, that we are not limiting our staffing, our capacity, and our hours of operations at our direct care environments or our public health labs. So far we've been able to work through that without any interruptions in workflow. Representative Sweeney, if I may, I think there, and I'm not suggesting this is what you were referring to, but over the past month and a half, the country has seen significant delays, especially in COVID-19 testing for private and reference laboratories. Partially due to the demand, when you saw, especially in the southern part of the country, a lot of new cases coming from COVID-19 over the past couple of months. There was a significant amount of testing demand that was out there, and private and reference laboratories did get backed up. So for hospitals or clinics that were using that infrastructure, you know, with their contracts with a private lab, we did have additional or similar anecdotal reports here in Wyoming that a lot of those tests were taking upwards of 7 days to return, which, you know, the more you get over, you know, 48, 72 hours, the less relevant the testing results are, because if a test takes 2 weeks to turn around, there's a 14-day period where even if the test result came back negative, that someone could have contracted the virus. So it really is important, as much as we can, to have quick turnaround time on the test. And we are doing that for the populations that we're able to test at the public health lab. In addition, some of the contracts that you see here, for example, the cheek swab testing procurements, the National Jewish Health additional testing volume, both of those contracts, we have 24-hour turnaround time requirements with those laboratories. So they have agreed to a contractual obligation of 24-hour turnaround time. That is, I think, more difficult to get with other labs, with other contracts. So we're trying to work through the best way to continue to expand our testing capacity, in addition to bringing on new technology in the state of Wyoming at the public health lab to do things like test saliva, you know, bring on machines that we could potentially deploy in a mobile setting that have quicker turnaround time. So it's certainly an ongoing effort, and we're trying to take a very diverse investment strategy, knowing that none of this has been perfect since this pandemic hit. But I hope, Representative Sweeney, that at least addressed some of your questions, but happy to follow up with you offline if you have additional information that you need.
Oh, that's helpful for me to go back to this specific group. So thank you.
Okay. More questions on the CARES Act funding? I don't see any. Okay, were you going to do separately a discussion on the prescription drug importation study?
Madam Chairman, I will hand that over to Mr. Fuchs to go through where we are with the pharmaceutical importation study that was authorized in the most recent legislative session. Franz,
okay,
take it away.
Thank you, Madam Chairman, members of the committee. Again, my name is Franz Fuchs. I'm a policy analyst with the Wyoming Department of Health. And Madam Chairman, at your pleasure, I can either just provide you a brief update saying we're working on this, or I can go through these slides. It's up to you and your timeline.
No, I think going through the slides would be fine. You know, I think there's still interest, and we try not to lose track of things that we ask people to do. Just because COVID's taken over our brain is no excuse.
Fair enough. So we are on track for completion on October 1st, and we've done some initial analysis thus far. We started working on this pretty much when that bill was being workshopped. So, you know, we've had, despite COVID, we've been able to make some progress, and we do have the highlights in this presentation. And just a real brief overview, if you only had to read this one slide, we have basically good news, bad news situation here. So the good news is we do see significant price differences. So if you took purely those price differences between Canadian drugs at face value and the drug and the cost of the drugs the state is paying for, or that Medicare members are paying for, there are potential for theoretical savings. Now, the somewhat good news, I think there are, you know, some work. It is possible to do this regulatory. There is a pathway for states to go through HHS and get this approved. Logistics are complex, but I think they're doable. We do have infrastructure at the state that would be able to handle multiple models of this kind of distribution, ranging from the liquor division as a pretty robust distribution network for the entire state, which could be leveraged to deliver drugs to retail pharmacies if necessary. Obviously, it's not free, but I think we could come up with a reasonable cost estimate that would take into account the economies of scale, the fact that you already have overhead costs being paid for at that division, and so on. And then we also have the medication donation program in the Department of Health, which is essentially a mail order pharmacy. So if the state were to choose that option as a distribution method, we could expand that program and its mission to not only serve those indigent clients who are being mailed prescription drugs, but also drugs that are being imported from Canada. So I think there are promising aspects of both the on the price side and the logistics side. Now, the bad news, one is I think seeing for consumers to actually see savings, if you're talking about your average Medicare Part D member, I think it'd be extremely complex to try to have that consumer see savings on the prescriptions they buy. And the reason is the main cost of those drugs is being paid for by a Part D insurer, which are regulated by Medicare at the federal level. And so you would have to get all these Canadian drugs on their formularies. You'd have to work with all these different insurers to try to get these new NDCs, new national drug codes. They'd essentially be new drugs for the purposes of regulation. And so these would have to be, you'd have to go through probably 5 or 6 insurance companies and try to figure out, how they would be placed on the formulary, under what tier. And I'm not sure we could guarantee the kind of cost savings on the cost sharing side for the patients. I mean, who knows what kind of cut they would take or what kind of cut the pharmacies would demand. So the kind of like the idea of importing drugs from Canada and passing those savings on to Medicare members, actually executing that on the consumer end, I think will be one of the biggest challenges. And then finally, we don't believe this program is sustainable at scale. We think it's, and we'll get into this, but you're basically exploiting this price difference with Canadian drugs. It's essentially a form of arbitrage. And whenever you exploit an arbitrage situation, that price difference will narrow for whatever reason. And we'll get into kind of what we suspect might happen. But either the Canadians will probably shut down the export pipeline, or the drug companies will figure it out and put restrictions on place on their market in Canada. So that's a brief overview of kind of what we're going to go into in the next couple slides. The study outline, as there are obviously a lot of more requirements in legislation. We do hope to have a sort of a primer on the drug industry, talk about kind of the manufacturer cost side, kind of the role of wholesalers, of PBMs, of insurers, and kind of how the whole system fits together. We'll talk about sort of the economic fundamentals that are really driving the cost of prescription drugs in this country, really focusing around the high hurdles to drug development and the research burden there. Talk about the role of brands and generics and so on. And then the strategies employed by insurers and pharmacy benefit managers to contain costs. So these are sort of a primer section, section 1 and 2, which will hopefully provide some background on the situation. 3, we'll kind of talk about the logistics. Like I already mentioned, various options of either using the liquor division or using the medication donation program as potential vehicles for this. And then we also have a couple other sort of cats and dogs that were added to not just this bill, but there was another bill on the, I believe, House Bill 2 on the agency reports regarding bulk purchasing. So we will try to address all of that in the same study. That's kind of our proposed outline for the study. Unless there's any questions, I can kind of get into some of the substantive slides.
No, I think let's go ahead and you can get the questions all at the end. That might save you from repeating yourself.
Madam Chairman, so just going back to that price difference. So this is, again, a theoretical sort of face value of potential savings. We took a list of 27 drugs from EGI where this made sense, where the price difference was substantial enough and it was not insulin, it was not a biologic, it wasn't a controlled substance, drug that's feasible to import. If you manage to coerce all the state employees who are taking those drugs to switch to the Canadian drug, which is a total volume of about 700,000 days in the year, that's a real price potential savings. And it's large, it's $10 million, because that's all state general fund that's paying for the EGI cost. It's not cost sharing on the members that we're saving, it's the actual cost to the state for buying those drugs. So this is probably the biggest bang for the buck. The single biggest bang for the buck is the state employee plan, because in theory, those members could be persuaded or coerced to switch to these drugs. And in theory, the drugs can be imported at where the price difference makes sense. So that's kind of the best case scenario, I think. I understand, however, the real intent of this legislation, if you look at it, is really about distributing drugs through the state of Wyoming to retail pharmacies. And so when we're looking at that, well, I'm sorry, I have one more slide here I forgot to mention as an example. So we just take one drug here as an example, the brand name Eliquis. It's primary ingredients called apixaban. It's essentially used for preventing blood clotting, deep vein thrombosis, and stroke. And it's a specialty drug. It's listed pretty high on most insurers' formularies because there are a lot of lower cost alternatives. Warfarin, for example, is a alternative that probably has a little more chance of complications, but does basically the same thing. So the reason this is expensive is because, it is expensive, but also insurers have, they price it high in their formulary. So there is a lot of cost sharing on members typically for this kind of drug. You can see the stats on how many members in EGI take this drug in a year, in calendar year 2018, how many days were filled, and the total annual spend. So that's almost $1 million of annual spending on this one drug. And of that, EGI paid 95% of that. So state general funds on a cost per day basis were approximately, so cost per prescription day, right? It's a certain, I think it's 2 pills in this particular case, $12.69. The Canadian import, when you convert to US dollars, you add a 45% markup, is $3.66. So you can see the delta there between the Canadian price and the price that we're paying is real. $9 times that many days is approximately $500,000 of potential savings, right? So this is just a theoretical face value example of one of the biggest bang for the buck drugs that we've identified in EGI's drug data. Now, I think there's less potential here. We did a similar analysis for Medicare Part D. So all of this data of what drugs are being purchased, how many, and so on, it's all public data. So we can leverage that and do the same estimate for Medicare members. Now, the difference here is instead of cost to Medicare or cost to the state, we are considering the cost to the consumer. We are looking at the cost sharing component of these drugs, because our objective is not to maximize cost savings from the Medicare program. Our objective is to really maximize the savings to the seniors who are actually buying those, doing the cost sharing on those drugs. And in that case, when you look at that from that aspect, there's a lot more drugs being consumed, a lot more members, but the theoretical savings are much less because we're looking at the cost sharing component, which is a fraction of the total cost of the drug. And again, here we're looking at approximately $3 million a year of consumer savings, again, with really strong assumptions and even more strong assumptions here, because we cannot just get these drugs to retail pharmacies and assume that consumers will be able to buy them. That we have to work through the Part D plans, and we have to get them on the formulary. And we don't know what they're going to be setting the cost sharing at, what tier these new Canadian drugs will be put at. It becomes a lot more complicated than, for example, EGI, where EGI has a lot more control over its own formulary and the cost sharing for its members. So again, there's a lot of things here that will be out of our hands. The coordination with Part D plans, I think, is really one of the bigger obstacles to ensuring that we can really distribute drugs across the state and get those savings into the hands of consumers. And just as an example, we looked at, for example, this is cumulative enrollment for Part D plans. So you look at the insurers range from the biggest at the bottom to the smallest at the top, and the dark green is how much enrollment they had of Medicare members. So for example, Humana has approximately just under 20,000 Medicare members in the state on their Part D plan. And then you look cumulatively, so United Health Group has maybe around 12 or 15, and then CVS a little bit less, and so on and so on. So just to get 80%, 85% of market share, we would have to get on the formularies of 5 different insurers here. And I think those negotiations could be very complex, and there's no guarantee that the savings, again, would be passed into the hands of the consumers. And this is one area where I'm really, where we need further research. I don't know how this works. I'm not sure who to even talk to. I tried calling the consumer helplines for United Healthcare Group, and I was bounced around between like 5 different customer call centers. This is a very unique question. They're used to dealing with seniors with Medicare Part D questions, not who to talk to, how to get a drug on a formulary. So this will be, I don't know if I'll honestly be able to have a good answer for you by October 1st, but it is an important complication we need to point out. Again, this is kind of what I was harping on. Even if we manage to successfully import the drugs, which is a regulatory rigmarole in and of itself, even if we successfully distribute the drugs to the pharmacies across the state, and even if they were placed on formularies, we don't know how much of that price difference will be kept by the insurers. That's really subject to the negotiation of being placed on those formularies. So again, I think the guarantee of savings from a consumer perspective is pretty thin. And then there are some fundamental problems with this whole approach. And this goes back to sort of microeconomics. I try to leaven this with this dry economic talk with a little humor at the end. But so the main question is, okay, why are these Canadian drug prices lower? Why are we seeing these massive price differences between the US version and the Canadian version? And the answer is, so many other countries, not just Canada, most other countries in the world really just have this they have some ability to say no to drugs. They have various regulatory bodies that basically can say, hey, is this really worth it? Is the effectiveness of this drug worth it? And what price really should we be paying for this drug? And if the manufacturer is not willing to supply the drug at that price, it doesn't get supplied. So it really is an access issue. It's again, that tension between access and cost, we keep coming back to that. But the ability to say no to drugs is really leverage that you have in price negotiations. And that applies to if you're Canada, it applies if you're the VA. The VA has a very strict formulary and they routinely say no to various manufacturers. And consequently, those members who are covered by that plan on the VA or in Canada don't have access to certain drugs. And so that's really the fundamental kind of trade-off at stake. So the fundamental point here is that these other countries have a lot softer demand as far as an economic, when you think of a supply and demand curve, the demand curve in these countries is much more what's called elastic. So it's much more responsive to price. And so why would these companies sell to the Canadian market despite the lower prices? And the answer is really this, we believe anyway, it relates to this economic concept called price discrimination, where if a seller can really identify a certain market segment, it can maximize its profits by, in the face of those differing demand signals, by setting different prices for those different consumer groups. And because drug development, drug companies have extremely high fixed costs, we're looking at approximately 30%, of their costs are going into research, for example. And then they have another 30% that's overhead. So really their marginal cost, once they develop the drug, once they have the pill, the intellectual property, and it's been tested and gone through the FDA's hurdles, how much does it cost them to make an additional pill? Not a lot compared to what their average cost to get that pill is. And so if they can sell that marginal pill to Canada for a much lower price, that's just gravy for them. So that's really why this whole system can exist, is because of this phenomenon of price discrimination. And you see this in today. I mean, analogy here is movie theaters. Why do movie theaters have different prices for students? Why do they sell lower cost tickets to senior citizens? Because both of those groups are much more price sensitive to the movies than full freight adults for various reasons. Students generally have less money. Seniors have more time and they can go to the matinee. They don't have to go to the main, the evening feature, right? So the movie theater can identify that market segment, say, hey, if you have a student ID or we can see your driver's license, we can give a lower price to that segment of the market. And so the real, for this silly analogy, I have it's not really apropos, but I have the two kids in a trench coat picture there. We're thinking of what happens if adults, full freight paying adults, start posing as senior citizens. What would happen to that price discrimination system? And the answer is either the seniors would get really upset about people taking away their senior discounts, or the movie theaters would stop offering that discount entirely, or some combination of both. And I think the relationship with Canada is that the drug companies would figure it out if enough people took advantage of this. Other states are exploring this. Florida is well ahead of us. Colorado is well ahead of us. If the state of Florida were to start buying its drugs from Canada, it would completely overwhelm that entire supply system. They would consume far more prescription drugs in the entire country. And we have been in discussions with the Canadians and the Canadian consulate, and they are not looking very favorably on these drug importation plans, and will essentially write us a letter that will include in the study saying, hey, if this gets out of control, it might work for one or two, kids to get into the movies, but once it starts getting exploited at scale, they would probably create export controls and shut down that supply crossing the border. Not to mention the drug companies wising up and imposing some restrictions on their own. So at the end of the day, this is not a sustainable system. We cannot expect these prices to last forever. So while at the end of the day, this might work for very small volumes. If the state of Wyoming had jumped on this really early and we'd gotten all the, through the hurdles and, we may have seen those $10 million for EGI, but the more people that take advantage of this, the less, we expect this to work. So the real question is, do we really want to invest in trying to build this infrastructure in a system that may not be sustainable for the long term? So with that, I don't mean to have terrible news for you in this presentation, but I do want to warn you about the overall tenor and direction of this study. And I'm happy to take any questions at this point.
Any questions for Mr. Fuchs, eh? Representative Yin.
Thank you, Madam Chairman. Mr. Fuchs, I appreciate the overview of the current progress of the study. And while it is a little disappointing, I think, especially when you describe it as an arbitrage situation, people still make money off of an arbitrage situation. And even if we can only make $10 million, if we only just did EGI plan employees and drugs, I think that it possibly may be worth it. The question is either if too many people get on it, the arbitrage disappears because prices start matching each other, or there's some other sort of regulatory block, which you outlined could be export controls by Canada. Would that be able to be assuaged by either having some sort of negotiations with Canadians and or trying to see if there are other places that you could import from, such as Germany or any other place that possibly might have lower cost drugs as well? Thank you, Madam Chairman.
Mr. Fuchs.
Yes, Madam Chairman, Representative Yin, those are all good questions. We will do our best to try to give the pros and cons in the study for legislative consideration as to whether or not it's worth investing, creating the investments like modifying the liquor warehouse to, be able to do this, or adding a position to be able to do the picking for the pharmacies and so on, or expanding the mail order option. We'll try to include those costs and benefits in here, but I can't really speculate as to, if we were to go to Germany or Mexico, what we can negotiate. I don't think really this whole situation will be decided by Wyoming. As unique as we are pretty small fry in this whole situation, especially compared to states like Florida. That kind of, whatever happens to states like Florida and Colorado will probably drive whatever happens generally to the US when it comes to importing prescription drugs, if I had to guess. But it's certainly, interesting questions. I think the costs and benefits you'll have to consider as a legislative body as to whether to move forward. We'll try to do our best job to keep an objective perspective.
Madam Chairman.
Representative Yin, did you have a follow-up?
Yes, please. Thank you, Madam Chairman. Mr. Fuchs, so are you saying that there are other much larger states that are also looking into this right now and considering implementing programs? Because if we're the only state that does it, I think that would last for a while. But again, if the whole country decides to import drugs from Canada, it's not gonna work, right? So how much forward movement are there in other states to try to pursue programs like this?
Mr. Fuchs.
Thank you, Madam Chairman. Representative Yin, we are not the first state. We are, I think there's about 6 states ahead of us that are probably a year ahead of us in this process. Florida is a year into this process. They already have an RFP out for Canadian wholesalers. I've been unable to find out much information from them because apparently they're in a blackout period with that procurement. So we are not definitely first in line for this. And I anticipate, I don't know how it's going to work out for Florida, but given just the fundamentals here, I don't see it working out.
Chairman Scott.
Madam Chairman, let me say at the outset that I agree entirely with France's analysis here. And it really comes down to a state government is not as efficient a smuggler as an individual is. And particularly our larger brethren will have effects that will force a reaction. I would point out, in addition to what he said, that we are the market where the fixed costs of R&D, of regulatory approval, et cetera, are recovered, along with some obscene profits and some other benefits that the drug industry gets, and along with some advertising costs that may be unfortunate. But if we were to join on a scale, as the states are proposing, we're going to just regulate you so you don't recover those costs. What you do is you kill off the drug industry R&D, and you have all kinds of perverse effects you don't want to have. So this is, frankly, I think this is a problem that is probably beyond the reach of state government, and the national governments are going to have to solve it, because the rest of the world, frankly, is exploiting us. I don't see how the state government can fix that.
More questions for Representative Sweeney? Did you have a question, or are you just wrestling? Okay.
Yeah, thank you. So, Franz, I'm just curious on United Healthcare and some of the others. Are you working at all with AARP? Because I know they've through the national organization has certainly studied a lot of this and may be a useful aid. I don't know. And United is basically part of their programming on a separate version. So, so have you reached out to them, or have they reached out to you for any assistance?
Mr. Fuchs.
Thank you, Madam Chairman. Representative Sweeney, it's funny you should mention that, because the day I was cold calling United Healthcare's customer service line, I emailed Tom Laycock of AARP saying, let's have a little race here, see who gets to an answer first. You through your AARP national contacts, and me through cold calling a customer call center. And I'm not sure. I'd have to talk to him. It was just a couple days ago, so I'm not sure how much progress we made, but we certainly reached out and are working together on this.
Thank you.
Representative Barlow.
Thank you, Madam Chairman. So, Madam Chairman, my question for Mr. Fuchs was, the bill anticipated there may be some other programmatic or opportunities for drug savings of drug costs. Have they done any comparative type things or anything else to see if there's any other opportunities? Thank you, Madam Chairman.
Mr. Fuchs.
Thank you, Madam Chairman. Representative Barlow, we've been trying to work with other entities. I think both state facilities were trying to collect information on their drug costs, as well as Department of Corrections. I know Corrections has been going through a reprocurement of their healthcare contractor, and that's it's kind of we'll work through those issues, but that's kind of been a complication. I think there have been some contractual, their contractor's not been able to release some of the pricing information and so on because of that reprocurement. So we will keep pressing on that issue and trying to identify other areas where there may be potential savings within state government with potential subscription type models like Louisiana has done with Hep C drugs and with bulk purchasing. Those will be components of the study, but we have not completed made as much progress on that as I should, as I'd like. And that's on me.
You could blame it on COVID, Mr. Fuchs. That would always. We blame everything else on COVID. Chairman Scott. You're muted.
Chairman, in response to that, there are a couple of places where we ought to look. One he mentioned was the Hep C, and there to get enough volume to negotiate, because there are basically three effective suppliers, and there's an opportunity to negotiate, and Wyoming may not have sufficient volume. We probably have to make common cause with another state, and probably ought to do it pretty promptly, or the opportunity may disappear. In the drug savings area, this committee, I believe it was this committee, put through a number of years ago a program of consultation with independent pharmacists. I think we wound up actually using the School of Pharmacy over at the university, and we were getting savings of about $2,000 a customer when seniors called in and sought our assistance. We were getting them two ways. One was discontinuing medicines they really didn't need to be taking, some of which were over the counter that were just not effective. And the other was by substituting available cheaper drugs that did the same thing, and there's widespread opportunity for that. The program went away when Part D destroyed the market, and it wasn't worth, the feds were paying the bill, so it wasn't worth the seniors' effort to participate. That that's a program that might well work for the state employees because we were saving about $2,000 a piece. Now that was only for people that had multiple prescriptions. You couldn't, somebody just had one, you couldn't do that kind of thing. But it was a major savings. With the state employees, the market isn't going away. It's potentially there, at least from the state's point of view. We might have compulsion to get participants to participate, but it was very successful. And that's something that ought to be looked at in terms of reducing the costs in the state employees group.
That seems something that we might work into the EGI discussion. I know JAC has one of their interim topics, a review of the EGI. I might pass that along to them. Mr. Fuchs, do you have any comments insofar as you've been able to evaluate President Trump's recent executive order on the drug pricing and that sort of thing?
Madam Chairman, I'm afraid I have not.
Okay, I haven't mastered it either, but I believe there are several people who wanted to comment on this actually, but we're actually at the, is there any other final questions on this particular drug importation study, realizing that we'll get a more complete report at the October meeting? Okay, so then, Elizabeth, let's see who we've got for public comment for Department of Health in general. If we could put through the prescription drug people first, just while this is fresh in our mind, it'll be a little bit more tied to the topic. That would be helpful, I think.
Absolutely, ma'am. We have Terry Armitage and Tom Laycock. I'll let both of them in at this time.
And is Shabir Safdar also wanting to speak on the prescription drug?
I believe he had it listed as the WDH update on comments. We can let him in as well in case he does have comments, ma'am.
Oh, okay. Mr. Armitage, are you there? You have to unmute yourself.
All right. Chairman Wilson, do you have me?
Well, I do, but you know what? I'm just going to, Mr. Armitage is trying to find his unmute button.
Very good.
I saw him first, so what can I say?
There
you go. Okay, there you go. What do you have to tell us?
Well, Madam Chair, Co-Chair Scott, I represent the Wyoming Sheriffs and Chiefs Association, and being a lifetime Wyoming resident, having worked at the Attorney General's office for almost 2 decades, being an attorney for over 33 years now, I worked with law enforcement almost all of my career, and I'm pretty familiar with law enforcement issues and their operations. And I was asked by Byron Otakoven to address the committee on the legal aspects and the concerns of law enforcement on the idea of a drug importation system, whether it be from Canada or anywhere else. Besides all the feasibility problems that we're hearing already in this study, I wanted the committee to be aware that law enforcement has serious concerns. You open up this drug supply chain from, say, Canada to begin with, we're going to see more. We've already seen counterfeit drugs in Wyoming and every other state in the union. We'll see a lot more of that. That's going to happen. And law enforcement will have a heck of a time trying to sort out and find the counterfeit drugs, the adulterated drugs, the drugs that shouldn't be in the supply chain. And when it comes to prosecuting, most of these bad guys like to operate overseas. So it's very difficult to arrest them, to extradite them, and to get them convicted. So we're going to see drug cartels from not just Mexico or anywhere close by, but probably all over the world. Because if they can flood our market in Wyoming by substituting counterfeit drugs, low quality drugs, adulterated drugs, we can be assured they're going to do it. So there's going to be an economic impact on our law enforcement in Wyoming. And then the logistics of trying to deal with this problem is going to be pretty overwhelming. And I would just hope that the committee would take that into account as they work through this otherwise great idea of lowering drug prices. But it may come at a cost to our consumers who end up with some kind of a fake insulin, fake cancer medication, fake cardiovascular medication that may harm them, may not do them any good at all, may even kill them. So I'd like to see the committee factor that in as we work through this issue. Thank you.
Questions for Mr. Armitage? Mr. Armitage, if you could just sort of clarify for us the I sympathize with what you're saying, but I'm not sure I understand in a practical way what the cause of the higher number of counterfeit drugs would be. Would it be because of the tracking? Because the tracking process would be elongated through another country, and that there are thus more opportunities to mislabel things? Or would it be that actors in Canada could present themselves as a legitimate pharmaceutical wholesaler when they're not? Or could just flesh that out for me a little bit so I can understand it?
Sure, let me try. One concern would be a Canadian pharmacy may have such a demand for their drugs just in Canada, and they want our business too. They may turn and buy the drugs from another country with even lower standards on their medication, which brings the adulterated, the fake medicine, all that in, so to supply our market. So there's going to be a lot of opportunities for people to substitute bad things for the good pharmaceuticals that we're trying to buy. And where there's drugs involved, we know criminal activity flourishes. So it'll take a lot more effort. If the drugs that we try to import are stopped at the border, they're going to have to go through a process of inspection, I assume, by the FDA. And then what they don't catch there, we've got to catch it when they get to Wyoming, Department of Health or whoever, to try to catch it. And when we do, then law enforcement's got to step in. It's a criminal activity at that point, and they've got to figure out what it takes to make a case, to bring charges, to arrest somebody in a foreign country, to get them extradited, to get them conviction, and it really complicates things.
The drugs that we import now in the regular chain, whether from China or India or wherever they're produced, is the chain of custody, as it were, from the factory there and FDA inspector through shipping and importation. Is that essentially adequate to control that, or is that kind of loose already?
I believe it's really loose right now. That's why we're seeing counterfeit drugs in Wyoming and all the other states. Yeah, I think there's a lot of room for criminal activity in all this, even with the best intentions.
Okay, very good. More questions for Mr. Armitage? Okay, thanks very much.
Thank you.
Mr. Laycock, we saw you. Welcome back. Hope you enjoyed your lunch.
I did, it was fantastic.
Oh, that's good.
Thank you for asking. Thanks for the time. Committee, once again, I'm Tom Laycock, Associate State Director for Advocacy Communications at AARP. I want to throw a big thank you out to Franz Fuchs, the Department of Health, for looking at ways to help us reduce the price of prescription drugs in Wyoming. It's a very difficult subject to get concrete answers on, especially without congressional actions. Franz has put a ton of effort and time into this. We'd like to think we've helped where we can, and want to thank you very much for doing that. I also want to thank the legislature for the time to consider the issue. This study came out of House Bill 113 from last year. It made it through both the House and the Senate without a single nay vote. I think that shows that the lawmakers are very much in tune with their constituents. We see this as a huge pocketbook issue. And just to illustrate that financial point, research shows that in Wyoming, which cost of prescription drug treatment increased 57% between 2012 and 2017. At the same time, annual income for Wyomingites actually increased only 2.7%. I want to compliment Co-Chairman Scott. He is correct in our estimation that much of the onus for the high price of prescription drugs falls on Congress to fix a broken system that sees the government fund substantial R&D, and then kind of take things at full price as opposed to refusing to negotiate prices for programs such as Medicare. We also acknowledge the fact that we're not in this alone. Franz did a nice job of profiling the EGI program this morning. We also know its program is spending over $50 million a year in prescription drugs, and if a less expensive option could be found for that, that would certainly save the state money as well. We do appreciate the fact that it's putting some of its best into finding a way for all of us to take part in more prescription drugs. It's kind of interesting. I'll mention two things that have come up since this conversation started, but the first being the question of bringing from other countries and the relative safety. We were doing this last year. I don't want out anybody, but holy cow, there are a lot of people in the legislature who are actually already getting drugs from either Canada, Mexico, or somewhere else. And this could actually have some increase as opposed to people going on that says Joe's Canadian and making some orders. So we think this could actually maybe offer a little bit of safety in terms of some of this kind.
Mr. Laycock, if you'll just stop a minute. Committee, I am hearing a lot of beeping from Mr. Laycock, sort of like R2D2, and I don't know if it's him or if it's me. If you're hearing the same beeping, would you just wave your hand? 1, 2, 3. We have some beepings. I'm not quite sure what that is. Just check the position of your mic or something if you would. Don't know.
Okay. Any better at all?
Well, that sentence was better.
Okay.
I didn't vow about the rest, but
yeah. The other response I was going to have was Representative Sweeney. Just to follow up on your question, us being an insurance company, AARP actually doesn't sell insurance. We don't administer insurance. We do endorse a United product, but unfortunately, we've got pretty strong controls between anything AARP does and anything United does. So we are trying to track down people for France to be able to talk to, but unfortunately, side of that system, we're sort of treated. We'll keep looking for somebody in sources.
Okay, I got most of that. Are there any questions for Mr. Laycock?
Thank you, Madam Chairman.
Thank you, Mr. Laycock. Okay, I believe we have Mr. Softar or Dr. Softar. I'm not sure which it is, but welcome.
Thank you. Can you hear me okay?
I can hear you okay, yes. Where are you talking to us from?
I'm currently in San Francisco where my team operates.
Okay, well, your connection is good.
Excellent. So before I start, Madam Chair, if it is permitted, I actually heard some questions without answers that I would like to address about the laws around drug importation. Would that be okay?
That would probably be helpful.
Okay, so I did hear a Representative Yin ask a question about whether or not Wyoming could go to other countries besides Canada and look at importation. It turns out the 2003 amendments in the 2003 Medicare Modernization Act, the Food, Drug, and Cosmetic Act, that you would be taking advantage of it here with the Department of Health implementing a program, prohibit importation from any country except Canada. So it would be impossible without an act of Congress and the White House, which they don't tend to get along these days very well, to actually change that option to give you an option to go to Germany, for example. And then Representatives Barlow and Scott also talked about other programs to save money. And I can talk a little bit more about this, but West Virginia, which is a state with about 4 times the population of Wyoming, did a number of years ago kick their PBM out of their Medicaid program and use the College of Pharmacy to do exactly the kinds of medication management and formulary adjustments that I think it was Representative Scott maybe talked about, Representative Barlow, and they saved $52 million their first year of operating that. And that's real money for a state of a comparable size. And the final thing was I noticed the other witness from law enforcement did mention issues around safety. And one of the key things that's not in my presentation that's worth talking about is that Canada has no track and trace program. So today, every medicine that you get has a unique serial number applied on the factory floor if it's made for the US market. If it's made for the Canadian market, it has no such serial number. So there's no way to actually trace those products. So those questions seemed relevant. I didn't want to let them go hanging. So with your permission, I've just got a few minutes on previous importation programs that states have done that I'd just like to give to the committee.
Great, thank you.
So my name is Shabir Safdar. I run the Partnership for Safe Medicines. We're about 17-year-old nonprofit, and we're a coalition, and we're experts on drug supply chain safety and counterfeit medicines. And we're a coalition of pretty much everybody that touches medicine from the point at which it's manufactured until the pharmacist, the wholesaler and pharmacist that transact it and dispense it, and then patient groups as well. We have over 40 members. We've been a nonprofit for a long time. As a side factor, we actually don't accept any corporate money or members. It's just it's not appropriate. One of the things I'd like to talk about today is to really commend Mr. Fuchs from the Department of Health and the analytics he's done and the research he's done. It's very true that these programs look great on paper, but logistically are impossible to implement either cheaply or safely. And as one of the professors that studies these programs says, you get cheap or safe, but you don't get both with these ideas. Illinois attempted to implement drug importation from Canada, and they committed to inspecting and whitelisting and managing pharmacies in Canada, but also New Zealand, Australia, and the UK. And that was under Governor Rod Blagojevich. And this program, because it used federal money, was eventually also a count in his indictment when he stopped being governor. But what they found was that it's really hard to regulate a foreign pharmacy. It's really hard to regulate a foreign vendor. That you don't have any regulatory power. Your board of pharmacy can't take away their license. And you can stop trying to do business with them, but because it's easy for them to have a website up and send small packages of medicine through the mail, if they're small enough, they can evade customs. They can continue doing business with your patients, whether or not you want them to, or with your pharmacies. So their program, by the time they shut it down, there was a drop in uptake where it wasn't actually making enough money to justify the state budget outlays. And that's a real terrible thing. Minnesota also tried this under Governor Tim Pawlenty. And I think the thing that really killed the program, apart from a lack of uptake, was the fact that they went to Canada to do an inspection. And it was a pre-announced inspection, right? So it's the kind of inspection that you should never fail. And they found things that would have shut down a pharmacy in Minnesota, any one of them, cold chain drugs not being refrigerated, pharmacist techs doing jobs that pharmacists education and training is required for. And the real problem here is that the Minnesota state government had no regulatory leverage over the foreign partner. They could do nothing to stop them, and that's a real problem. Maine, so those were two programs where they tried to make it safe, but they didn't try and commit to saving money and being cheap. Maine in 2013 actually implemented a Canadian drug importation program, and they went the cheap route. So they didn't try and inspect pharmacies. And within 90 days, a professor of pharmacy at the University of New England ordered medicine that he saw advertised in the Portland, Maine Press Herald in a full-page ad, and he ordered it. And because he's a professor of pharmacy and chemistry, he brought it into his lab and he tested it, because that's what you do when you're a pharmacist. It's the kind of thing, and you have the lab. And what he found was that, first of all, the packages he got weren't from Canada. They were from Mauritius, India, and Turkey, which my geography is not great, but those are not provinces of Canada last I checked. And he found that 2 of the medicines had insufficient active ingredient, which means that they were half strength or 3/4 strength, and that would have created a hazardous health situation for the patients. In one case, his molecular testing showed that there was an impurity in there. And we know now from some of the recalls that we're seeing where there's traces of carcinogenic material in medicines, that unidentified products, unidentified substances in medicine are a very serious issue, and they can be actually life-threatening. So in that case, that program actually, same thing, it was running, it wasn't actually designed for state employees, but a federal court eventually struck it down as being illegal in the Food, Drug, and Cosmetic Act. I think one of the problems that was cited in the very good report from the Department of Health is that the Canadian government has a role. And the Canadian government has not only met, I suspect, with folks in Wyoming, but they've actually met with people in Florida, Maine, Vermont, Colorado, and New Mexico, who are all way ahead of you in this process. And they've told them the same thing, which is no. They've been to the White House and said no. This program doesn't get authorized because HHS authorizes Wyoming's application. It only works if both HHS and the Canadian federal government say you can do it, because the Canadian federal government possesses the ultimate veto. And they've been very clear that this is not actually going to happen. And the reason they don't want this to happen is because their population is 1/9 the size of the US. They don't make their own medicine for the most part. And they already have about 1 in 7 to 1 in 8 drugs in shortage. Every pharmacist that places an order today in Canada talks about how anywhere from 1/10 to, in some cases, 1/3 of the order doesn't arrive because it's been back ordered without a clear date on when it's going to arrive. This is what's driving the Canadians' objection. If Florida, as Mr. Fuchs said, would order medicine in any quantity that would cause a shortage, Canada can't make enough of the medicine to backfill it, and they would be left in a lurch. And it's not like medicine that is in the UK is immediately applicable to Canada, right? The labeling is different, the languages are wrong, sometimes the dosing is different. And if you ever talk to your pharmacist, even something as small as different dosing on a similar looking package can be deadly, because you can end up taking medicine that would be in a quantity that's either not enough to cure your disease, or so much that it actually creates a medical crisis. So these are some of the reasons driving Canada. There's another issue as well, which is that if you look at the 2003 Medicare Modernization Act and the Food, Drug, and Cosmetic Act part, where this program, if implemented, would be governed by, you have to statistically sample and test the medicine that you buy from Canada. So this professor of economics at Colorado College has a recent peer-reviewed paper in the Royal Pharmaceutical Society Journal, and she actually took medicines that Senator Bernie Sanders and others had proposed to import from Canada, and then looked at what the cost of testing would be and what you'd have to do in terms of quantity to get a statistically relevant and confidence and reliability of 99%, for example. And she found that very clearly, any savings you might hope to make would be obliterated by the cost of testing, because testing costs $2,500 to $4,100 per sample. And so when you see the one issue I would take with the analysis is that the idea that you can mark up medicine by 45% and that covers all of your program administration is probably low. In terms of other solutions, there are often certain drugs that are not generic that drive drug costs, but for the most part, actually, when we look at costs of medicines in Canada and America, for the top 50 medicines that are dispensed in America by volume, 47 of them have generics. And those generics are actually cheaper when we price compare from Toronto pharmacies to pharmacies in Chicago. So there's a real, I think, opportunity there in some cases just to look at the generics, and it's cheaper here than there. The other thing is that the Eliquis, which is what was used in the Department of Health analysis, has actually 2 generics that were approved in the last 8 months. And so when those hit the market, those will drive down costs without the state having to actually expend any money. So those are some of the history of importation programs. I hope I've been helpful. I will send these slides and my written comments to you for distribution to the committee, and I'm available to answer questions.
Thank you so much, Mr. Safdar. Do we have any questions for him? And don't forget your blue hand while the screen is still up there. I'm waiting just because the blue hands sometimes show up rather late. Representative Sweeney.
Thank you, Madam Chairman. So do we just give up?
I don't believe so. Madam Chair, I apologize. May I answer that question?
Certainly, go ahead.
I don't believe so, Representative Sweeney. I think you should put your efforts into places where you do have influence. I think regulating PBMs and how they operate in your state is a big one. Looking at the formularies that your government employees use and whether or not they could be switched to generics, because generics, if you look at, are the biggest driver. And then the subscription ideas and group purchasing ideas are very interesting. I actually noticed when studying the Washington State Hep C subscription model that contract that they eventually gave to one of the manufacturers allows for other states to join their compact. And I don't know if any other state has done that yet, but I do believe that is a success route for states, not just for Hep C, but for lots of medicines that they are worried about. And I think that those take work. And I think, by the way, that's a great way to employ your pharmacists and your pharmacy students.
Senator Bouchard.
Thank you, Madam Chair. You know, I just looked at that study, and I want to disclose here that that study was paid for by them. So, I mean, I always want to look at a study and see who pays for it. And I've also looked at other states. Utah is allowing public employees to go to Mexico, of all places. A totally different direction. But anyway, disclosures on studies are important to me, because whoever is paying for the study normally gets what an answer they want. So,
Senator Bouchard, if you could, I couldn't hear the beginning. There was a kind of a cutoff in your. Who did you say it was paid for by?
His organization paid for this study. It says, the disclosure here says, I'm just going to look at my screen here.
And which study was this?
It's the one he meant, the cost effectiveness of analysis of importation. It was a presentation, and I went and looked up the study, and it's actually paid for by Partnership for Safe Medicines. So it's kind of like there's an agenda there. Anytime I see a study, I want to see who pays for it.
Madam Chair, may I respond to that?
Certainly, Mr. Stockdale.
Yes, we did pay for that, or at least we paid for the funding of the completion of the study after the hypothesis was brought to us. But I encourage you to read it. The evidence is very clear, and there were no liberties taken with the actual math and data. You could reproduce that data all by yourself, and you come to the same conclusion.
More questions for Mr. Stockdale? I'll just pick up from that, Mr. Fuchs. You recall that we had that request, which you mentioned, for Department of Health and Department of Corrections to look at sort of the Louisiana Hep C situation. And so I believe I heard Mr. Stockdale say that state of Washington's had the possibility for joining. So you can just sort of stick that sticky note into the whatever you're working on with Department of Corrections in your spare time. Okay, any more? Okay, Mr. Softer, thank you so much. That was very, oh, I'm sorry, Representative Sweeney has a question. You gotta think faster, Pat.
Sorry, are there any known ways or co-ops or whatever on insulin, you know, to get the cost of insulin down?
Madam Chair.
Mr. Stockdale.
So I have not actually studied too much about the details of cost of insulin. The 2003 Medicare Modernization Act, which introduced the possibility of importation programs, specifically excluded biologics, of which insulin is one. So these programs don't address concerns about insulin. Additionally, the Diabetes Canada and other groups representing diabetics in Canada, if you start to talk about importing insulin to them, they panic. In terms of a subscription model or other possibilities, I haven't seen that, but I would think that subscription models or group buying purchasing programs would be a good way of addressing insulin costs.
Committee, I do know Senator Scott and I heard some about this a year ago when we were in Louisiana, and our Medicaid program is part of a purchasing group that deals with purchasing medications for Medicaid patients. Obviously doesn't apply to other non-Medicaid patients, but it's got quite a number of 20 states or something, I don't recall. Okay, Mr. Sefter, thanks so much and we look forward to receiving your presentation. Just send it through LSO and they'll share it. Thank you. Elizabeth, were there any other people specific to the pharmaceutical importation? Otherwise, you can start bringing in whoever else we had for Department of Health.
Ma'am, I believe that is all the public comment we have for this topic. Those are the only 3 individuals on my list.
Okay, so nothing else for Department of Health in general public comment?
At this time, correct.
Okay, then let's go move on to, are people feeling the need for a break or can we continue? People look happy enough. Okay, DFS. Well, I guess we know what their report on agency budget reductions will say, but Director Schmidt or whoever's here from DFS, we would be glad to hear from you. Director Schmidt, we can see you.
Hello, Madam Chairman, how are you?
Well, we're poking along. How about you?
About the same, thanks.
Okay. So let us know what you've got to share with us today.
Okay, well, good afternoon, Madam Chairman, Mr. Co-Chairman, and members of the committee. My name is Corinne Schmidt, and I'm the Director of the Department of Family Services. We were asked today to present to you on 2 topics, the first being the budget reductions. And as you all are aware, those have not yet been released, so we won't speak to those today, but we are ready to inform our staff and our stakeholders when we do get permission to move forward. The second issue is in regard to the COVID funding that we've received as the department. And like Mr. Johansson had said, the Department of Family Services has received all sorts of COVID fundings through 2 different funding streams. One is our usual federal partner relationship, whether that's through a grant or some sort of 4E is an example of a funding stream. And the other is from the CARES Act, the $1.25 billion that the governor's office has submitted to us. So I'm going to start with the direct. And before I go very much further, we did submit a handout. And the information that's in the handout is basically what I'm going to hit on today. But fairly soon into the epidemic, the pandemic, we received about $4.1 million through our child care block grant. And our child care block grant is used for a variety of purposes, but most importantly, it's to provide assistance to eligible families for child care services. So if we have an eligible family, we can assist or subsidize that child care payment. Those payments go directly to the providers. So when we received the $4.1 million last, I think it was in April or May, we divided that pot of money into 3 areas. The first was about $1 million or so to continue those assistance payments for children who had gone to childcare in March, but maybe had not gone throughout the rest of the COVID season. And the reason why those child care assistant payments were made is because it's an infrastructure payment, understanding that those providers still had costs associated with businesses, with providing the business if they were open, but also anything related to COVID. The federal government allowed us to continue to make those assistant payments. A portion of the 4.1 went to all child care facilities in a one-time grant, a one-time payment. Depending on the size of the facility, the one-time payments differed. And of the 1.5 that we allocated for those purposes, about 1.4, about a little over 1 million has been distributed. So those dollars are going out the door and going directly to the child care facilities. And then the last portion of that 4.1 is about $1.7 million that are made available for grants based on an application. Up to $10,000 is available for child care facilities to apply for anything that's related to COVID that meets the law. Because of the way that we receive these dollars, there's a little bit more flexibility than the CARES funds that were provided to the governor's office. So we've left those dollars open for anything from PPE to cleaning supplies to providing support to their staff, etc. The one condition that we have in any of these funds that we've received is that providers can't double dip. So if they had received money, for example, from the Wyoming Business Council, they have to note that, and they cannot ask us for money to pay for something for the same thing. There was a conversation earlier about homelessness. So far, we have been allocated about $4 million in homelessness through the Housing and Urban Development through HUD. However, to date, we've only received a little over $1 million of those dollars, about 1.1. So those dollars will be distributed via contracts to our agency, to our regional agencies to distribute to local entities within their regions for things such as rent assistance, deposits, utility payments, emergency shelter, etc. Those contracts are going through our process right now to get to those 6 regional areas. And then those dollars will be going to the various agencies they support within the communities. We have not yet received the remainder of the $3 million from HUD. We just know that it's been awarded to us, but it hasn't been released to us by the federal government. So when we receive that, we will start distributing those dollars as well. The good news is that we're not confined to the December 30th deadline like the CARES money is. We have until September 22 to spend these funds. We've received $2.4 million in energy assistance through our LEAP program. That's the program for eligible households that need assistance paying energy bills. What we've done with those dollars is we've extended the season. Typically, that's a seasonal program that starts in the fall, ends in the spring, and it, like as I said, can pay for assistance with utility payments, or maybe if there's back payments that are owed or we need to have something turned back on, we can use those funds. With the additional funds, by extending the season, we've been able to pay for assistance with heat, with air conditioning, which is not something that we've needed to do or we've done before. So that's been interesting. We can help with repairs on AC equipment so that those people that are at risk and that are eligible have some way of staying cool if they're in an area, of course, where we see extreme heat. We have received through our food assistance program, it's a bulk food program. We've received an additional $1.3 million. And those dollars go to the Wyoming Food Bank of the Rockies. The federal government purchases food allowed by the federal government. That food gets shipped through the Wyoming Food Bank of the Rockies, and then they distribute it. So the Wyoming Food Bank of the Rockies is a food bank that does a lot of distribution of funds through their network. So they provide food allocation to almost all corners of the state. Sometimes the reach is a little bit harder when you're getting from Casper to Afton, so for example. But those dollars those foods are available for families if they meet the eligibility criteria. It is a means-tested program. It's the same requirements as SNAP, which is the Supplemental Nutrition Assistance Program, which is 130% of federal poverty. So this is a program that is specific for people in poverty. And then we've received just a small portion of money through our Administration of Children and Families. to help with some of the costs in our child welfare system. And that was about $61,000. So not a lot of money. And we used that early on to support the tribes with some of the equipment they needed when they had to close their doors due to the COVID outbreak, so that they could telework a little easier from their homes within the reservation community. So those are direct appropriations to the agency from our federal government streams. Indirect is a little bit of a different story. At the federal level, the SNAP program was appropriated a lot more money for food benefits. We administer the program, which means then that we make the determination of eligibility, and then we make the determination of the amount of the benefit. What the federal government allowed us to do with the increased SNAP benefit is in any given household that was SNAP eligible, we could pay the full allotment. In a non-COVID world, we would look at the household, the assets, and then make a determination of up to what amount that family would be eligible for. In the COVID situation, whatever the upward amount is for that family, we would just go ahead and issue it. So since March, we have seen a $2 million increase in the issuance of SNAP benefits. A lot of that having to do with going to that maximum allotment. We have not seen the increase in the SNAP benefit program that you would expect. That's mainly because the unemployment insurance program that the Department of Workforce Services has been managing, those dollars are included as income. And so that is what's making what we think probably a lot of those families ineligible. We expect an uptake at the end of this month. Once we pull the August numbers, we do expect to see an increase of SNAP applications as a result of the unemployment program ending in July. So we're watching that pretty carefully to see what will happen to our system. Again, the benefits are paid for by the federal government, but we do have to determine eligibility and process the applications. Also, in regard to food security and assistance for families who are facing a food shortage, we participated in the voluntary pandemic EBT plan that was offered through the federal government. That is a program that allows for children who participate in the free or reduced lunch program to receive additional benefits. So while those children and families may be receiving food directly from the schools when school was in session, the PEBT program, the pandemic EBT program, allowed us to issue food benefits to those families in addition to whatever they were receiving through the schools. We were able to award about $1.8 million in food monies for those families. We're also working with our federal partners to see if we can continue to provide that program. We're working on our plan. Right now, the plan is slated to end at the end of September. So we don't know if we'll have enough time to actually get anything done, but we're giving it a shot. And then we also received some indirect funds through the Administration of Children and Families, an increase in the FMAP, and you all are familiar maybe with FMAP through Medicaid, but we received a slight increase in the percentage of federal dollars that we can claim for guardianship and adoption subsidies. It's been a small amount, it's 6%, but every little bit has helped. And then directly from the governor's office for the CARES Act, the $1.25 billion that we keep discussing, we did receive $1 million in mental health and substance abuse dollars. Those dollars will be starting to spend as of September 1st. And those dollars were very specific. We requested money to assist us with accessing mental health and substance abuse treatment, evaluations and treatment. We expected an increase in intakes on our child protective services side because we knew when schools were no longer in session and we saw a substantial decrease in reporting. Even though that the reporting went down, we also we're very concerned about the number of children that maybe that are experiencing abuse. And once the society started to open a little bit, what would we be seeing and expecting in terms of intakes? Intakes are increasing. We expected that they would start in July, and they have started. So through the course of the next few months, we wanted to be able to have access to money to be able to put services immediately into place, mental health and substance abuse services, so that we could do our best to keep children safely at home or return them home as soon as possible. And we also received $1 million in food insecurity funds. Those funds have not yet been contracted out. Our plan for those dollars is to split them between the Food Bank of the Rockies and another nonprofit for direct distribution to replenish any of the pantries, or to help with some of the supply chain issues or storage issues that many of the pantries face. So many of the pantries throughout the state may be able to get food, but storage is a problem. Refrigerators, freezers, space, shelving becomes an infrastructure issue for so many of those pantries, so that when they do get food, they need to be able to safely store it. So the $1 million will be spent on a combination of either replenishment of foods or infrastructure needs that a pantry may have. And then last, we received another $4.1 million in child care assistance. Those dollars are still going through the process. We anticipate that we will continue to provide one-time grants to child care facilities. We will continue to provide assistance payments based on participation in the child care assistance program. And then another request that's been made of us that we're looking into is being able to provide direct assistance to families who have maybe incurred additional costs as a result of closures. That one is a little bit trickier. We're trying to figure out how it is to directly distribute money to families. We're working with a few community providers and nonprofits to see if perhaps they could act as our fiscal agent. If we're unable to pull that off, then we will go back and put that into the fund for those larger grant opportunities for childcare facilities who are incurring costs due to COVID. So, Madam Chairman, that is a very quick summary of how the funding that we've received and how we are spending it. And I am certainly available for questions.
Great. Questions for Director Schmidt? Senator Schuler.
Thank you, Madam Chairman. Just one question on this last part of the governor's money, the 4.1 for the child care.
Mm-hmm.
How does that, I guess, what does the application process look like? I know you mentioned something about nonprofits might be able to be a fiscal agent and it be a one-time grant or whatever, but how would families access that money? Just out of curiosity.
Chairman Wilson, Senator Schuler, that's what we're trying to figure out. Montana has started a program, so we're going to be asking them how they've done it. I mean, theoretically, what we would anticipate is that there would be an application to an entity. It's hard for the state to distribute directly to a citizen, right? And so our idea is that we would like to take those dollars, give them to a nonprofit as a fiscal agent, and then they would process the applications essentially. So we were hoping for it to be online, and then there would have to be some demonstrated need. So what is the cost that was incurred? Why was it incurred? Had they received any other COVID dollars? And then whatever documentation that will wrap around that. So it may be, some sort of receipt or invoice or something that says, yes, we did incur this additional cost. What we're finding with childcare, and as maybe some of you have experienced, is the accessibility of childcare has been very unpredictable. When the original orders were issued, childcare centers were left open for essential employees. And so surprisingly, we had a good number of childcare facilities that did stay open. But those that didn't, there were some significantly large ones that did not. And so parents were having to scramble and figure out how it is to provide to care. Even though now we have a good percentage, about 70% of our facilities are open, We're still seeing closures. We're still seeing parents having to make alternative arrangements. And for some of those parents, that's just really tough. So that was an idea that was proposed to us. And so we're digging into that to see if we can logistically pull it off, because all the funds up until this point have been going to the businesses, the providers themselves, without, certainly in support of families, but really no thinking about direct support to families.
More questions for Director Schmidt? Representative Sweeney. You're muted still.
Thank you. So a few questions on the child care. Was there any opportunity once the Boys and Girls Clubs, YMCAs open back up on any of the funding you headed that direction under that portion of funding?
This is so hard, Chairman Wilson.
Go ahead, sorry.
Representative Sweeney, those are sometimes not, depending on their exemption status or their licensure status, yes, they can apply for those funds. We actually funneled a lot of those dollars through Wyoming Kids First, again, needing a fiscal agent, and they're managing a good portion of the grant funds that are available to our child care facilities. So we have reached out repeatedly to our child care facilities through emails, through all sorts of communications, informing them of these grant opportunities. And in fact, we've talked to the boys, the boys school, or not the boys school and girls school, but the Boys and Girls Clubs directly, including the one in Casper. So they're aware of these funding opportunities. The original 4.1 that came directly to us from the federal government was prior to any of the funds that shifted to the Wyoming Business Council. So in some respects, we had some money, we were able to get it out, but there's always the opportunity through the Wyoming Business Council for some of those entities that operate as businesses. So there's a few different sources available to them.
Follow on the homelessness, even though you've only gotten a little over $1 million on that so far. When you talk about the regional, so have money's gone to Camilla House there in Cheyenne, Central Wyoming Rescue Mission, or is there a different mechanism to apply for those funds?
Madam Chairman, Representative Sweeney, so the first round, the approximate $1.1 million is going to agencies in every region, of which Camilla would be one. And then the dollars will be provided for various opportunities such as prevention, emergency shelter, etc. So that's the 1.1. The additional dollars, the additional 2.9 or so, are going to be more targeted based on needs assessment. We have a little bit more time to spend those monies. So the process for that is going to be somewhat different. I'm not quite sure exactly what the difference will be, but the idea behind the original 1.1 was just to get it to the regional agencies as soon as we could. And then we have a little bit more time to be targeted around the remaining 2.9 that we have yet to receive. The contracts for the first part, the 1.1 that will go to the 6 agencies, are in the process of being executed. They're going through the AG's office right now.
Okay.
More questions for Director Schmidt? Representative Sweeney.
Sorry, Madam Chairman, on food assistance, the 1.3 million. So you mentioned Food Bank of the Rockies, which has done a tremendous job. Was Meals on Wheels in our different communities or any of those also provided assistance, or was there a different mechanism?
Madam Chairman, Representative Sweeney, the dollars that we received for that 1.3 went through Wyoming Food Bank of the Rockies. If they distributed to a pantry, if one of the Senior Citizen Center Meals on Wheels programs was a pantry and they're part of their network, I would assume they would have been eligible for those food, but I don't know if they received them directly. And again, that program is one that it's a program we manage. It currently exists. It's not something new because of COVID. So it was merely a mechanism we could use. And the food is purchased and then directly distributed based on need. So that one is a means tested program.
Yeah. The Department of Health, Representative Sweeney, did say earlier that when they talked about the $5 million to aging, that some of that money went to senior centers, and I thought they mentioned Meals on Wheels at that time, but that may have been my note there's a little scribbly.
Thank you.
Okay, any more questions for Director Schmidt? Thank you very much for your update. We went well. Is there, Elizabeth, is there any public comment specific to family services?
Ma'am, we do not have any for family services.
Okay, well then let's go on to our last of the day, Department of Workforce Services. Oh, there's Director Cooley. You know, you never know where they're going to pop up on the screen. You know, it's going to look all about. Hello, Director Cooley. You're muted still, but we would be glad to hear from you.
All right, can you hear me?
I can hear you.
All right, very good. Thank you so much.
Thanks for bearing with us through our always extensive agenda that for some reason always exceeds what we thought. We always think that we'll put out as a good timing, and I don't know if we're ever right, but.
Okay, I think I had two screens up, so I think I've only got one up now. So am I good?
You look fine. Oh, you just moved. Where'd she go? You've disappeared and you've turned into Jason Wolf, which is also fine, but not the same. We've lost her.
Ma'am, we may need to wait temporarily while she reconnects. I believe she might have disconnected herself.
Jason, you might have to be in charge.
Yes, thank you, Madam Chairman. So we'll give Director Cooley a second to come back on. I think she wanted to kind of kick things off.
Okay, that's fine. We'll give everybody a chance to mute themselves and blow their nose or something. While you're waiting, we can ask Representative Yin, have you had occasion to run out with your blue balloons into the hallway yet?
Not quite yet.
Not quite yet.
These don't start for in a couple more hours.
Oh, okay. All right, welcome back, Director Cooley.
Thank you very much. Sorry about that. Operator error, I believe.
One of these months we'll have it all down, just in time for COVID to go away, and gee, won't we miss it?
Exactly, right? Well, good afternoon, Madam Co-Chair, Mr. Co-Chair, members of the committee. My name is Robin Cooley, and I'm the Director of Wyoming Workforce Services. What we would like to do, if it's all right with the committee, I will start out talking about the CARES Act funding and how that's been distributed. Because as you've heard, agency budget reductions are not ready for prime time just yet. And then I will turn it over to Jason Wolf, who's my administrator of workforce standards, to talk to you about the workers' compensation issues that you've requested information about. So what I would like to start with is the CARES Act funding summary that we provided you earlier. And I'm just going to go through what we've got in there, providing you with a little bit more context than what's in there, if I might. Starting out with the Workforce Development Training Fund internship grant program. This is a grant program that we actually put into place May of 2020. There was a lot of work prior to that. So it wasn't a COVID-related program. It was a program that we had intended to start up because we felt and we had heard from industry as well as education entities that internships were lacking in this state, and there was a real need to get individuals into internship opportunities in the hope that we would be able to keep them in the state once they were active in some of these employment opportunities. So we started down that road, got the internship program in place with rules. One of the stipulations to those rules from the governor's office was that we do not use general funds for these programs. So we do not use general funds for these programs, and instead we use what are called Fund 528 funds, which are interest funds that come off of the UI Trust Fund. I am happy to report to you that in the first several months of that program, even though we've not messaged it just yet, we were able to set up, let's see, what's the number, 23, I believe, 23 internship opportunities in industries such as agriculture, arts, construction, hospitality, law and legal, medical manufacturing, and information and technology. So right off the bat, this was a very successful program. So when the CARES Act funding came into the state, we thought that this was an excellent opportunity to look at the need out there for COVID-related internship opportunities and to open this up for those internship opportunities. So we did submit an application to the governor's office for some of those CARES Act funds, and we were awarded $750,000 for those funds. Though the funds will be awarded the same as the other internship funds are awarded, but we're requiring applicants to provide evidence of the public health or economic relief component of the proposed structured learning experience. And they will have to track the COVID internship grant subset separately just to maintain the integrity of those funds to be able to report and for auditing purposes. But I think that that's going to be a very successful program for internship opportunities around the state. And I do want to let you know as well, we do have a messaging program set up, and we'll probably start the first part of September for the internship grant program. And we're really hoping for good things from that opportunity. The second opportunity, or the second CARES Act funds we received went directly into the Unemployment Trust Fund. To replenish these funds, we received $25 million to stabilize the fund and to maintain the health of that fund to ensure the future needs of employers are adequately met. We're hopeful that this will help stabilize tax rates in 2021 for employers. However, I will be quite frank with you that in 2022 and 2023, there may be an uptick in tax rates regardless of these efforts. We just don't know. Up above here, it talks to you, tells you about those factors that we have to consider in determining what those tax rates are. And there's just no way to know at this point what the impacts to employers will be. But we're hoping that $25 million replenishment will assist that. I wanted to give you some quick numbers that I had off a chart that we keep, just to give you an idea of where we're at with our state UI Trust Fund dollars. When COVID started, we were at about, and these are rough figures, at about $346,575,000 in the fund. About a month, we're keeping track of this monthly. At the end of July, I believe it was, we were at about $299,594,000. So that gives you an idea, and that's without that $25 million added into that fund. So that'll give you an idea of somewhat of how we will be able to replenish those funds and the impact, the potential impact to that funding stream. Workers' compensation credits. As you'll recall, in the special session, there was an additional workers' comp credit that was awarded for employers of 8.33% credit on top of the credit that employers received from the general session as well of 8.33% for a total of 16.66%. We did receive CARES Act funding for the special session credit of $16,469,110.60. That is being used to replenish the workers' compensation fund to balance that credit out that is being provided to employers. So those CARES Act dollars are really being used to the benefit of employers and employees across the state. I calculated that's about roughly a little over $43 million that are being used to assist employers and employees across the state. I also understand you're interested in other federal dollars that are coming into the state for COVID-related purposes. So I wanted to give you some additional information on those. After COVID hit the state, we did also recognize that we were going to be needing additional dislocated worker funds. And those dislocated worker funds are funds that are awarded under the Workforce Innovation and Opportunity Act, or WIOA, that we implement through our 20 workforce centers across the state. So we did apply for and were allotted $200,000 additional dollars for dislocated workers. And that goes to help unemployed workers find reemployment, upskill. It helps them with resumes, with work interview skills, and other soft skills. So those dollars will definitely be put to good use. Also, as we implemented the additional unemployment programs, the Federal Pandemic Unemployment Compensation Program, which was the $600 additional dollars per week for unemployed individuals, the PEUC, the Pandemic Emergency Unemployment Compensation Program, as well as the PUA, which was the Pandemic Unemployment Assistance Program, which provided benefits to contract and gig workers, as well as a general UI administrative grant. So we got administrative grant funds for each one of those in order to implement those programs through our UI system. Those funds are being utilized quite heavily. We haven't used all of those funds up. And I can give you those amounts for each one of them if you would like, but I think roughly that's a little over $2 million that we received in administrative funds in order to get those programs up and running across the state. I also wanted to mention another stream of funding that we received. It was applied for through the governor's office. It's the GEAR funds. Through the governor's office and the Department of Education. What we were able to do with some of those funds is we took them and braided them with some of our training funds in order to provide some additional training fund opportunities for a business in Wyoming. So a very good use of some wonderful funding there. And that amounted to about $65,000 for that program itself. Another exciting thing we're doing in applying for funds, we've applied for what's called the Reimagine Workforce grant opportunity. And that's actually a U.S. Department of Education grant opportunity, an education opportunity. The total amount that will be granted to states or awarded to states is $127.5 million, which is a considerable amount of money. The difficulty here is they're only going to award 8 to 9 states with those funds. So a great part, as we were looking at their system of deciding who is going to receive the funds, the biggest part of this is going to be the impact COVID's had on your state. As we've looked around the state, and this is actually a Workforce Development Council grant opportunity. They were the ones that voted on it and voted that we should go ahead and apply for the funds. But as we've looked around the state, the impact to our state, to our energy opportunities around the state, and the double whammy, I guess you could say, that we received from COVID in that area, as well as in so many other areas in our state, we feel very comfortable with what we're putting in our application in terms of the impact that COVID has had on our state and on our communities and on our business and employees. So that grant opportunity, the application is due Monday, and we feel very comfortable with it. We've been working with stakeholders all over the state, with entrepreneurs, with the incubators around the state. There's a lot of good things going on around the state that we really want to showcase in this application that these funds could really assist the state of Wyoming with. So we're very excited about that opportunity, and we hope we'll know soon about that, and we'll announce it as soon as we can. I know you all might also be very interested about the Lost Wage Assistance Program and what Wyoming is doing with that. That's the program that President Trump signed the executive order to implement. The states can implement 2 different options, either the $400 option or the $300 option for Wyoming. You're getting a little bit of a scoop right now. We're getting our press release ready to send out, but we are going to go ahead and apply for that $300 option for Wyoming citizens and our unemployed individuals out there, in order to get that information to them, those funds to them as quickly as we can. And I think that's all I have as it relates to funding and funding sources and the individuals that are going to benefit from some of these funds. And I would stand ready for questions.
Great. Questions for Director Cooley? Representative Sweeney.
Thank you, Madam Chairman. On the unemployment trust fund, so there won't be any ability because of the way this was statutorily set up on the 3.5 to 4% excess, in order to not increase their experience rating even in 21 because of the pandemic. So did I hear that correctly, that the 25 million really doesn't take us to where we need to be, and so we'll end up no fault of the employer, their experience rating will increase?
Director Cooley.
Madam Co-Chair, Representative Sweeney, that's a possibility. We won't know because it's based on the amount of the fund as it related to last year's total funding. We won't really know the answer to that, but there's a possibility that even with this $25 million added to that fund, that employer rates could increase. Now, keep in mind, during the special session in Senate File 2, there was the provision granted in there to allow the governor through executive order for a period of time, as long as it allowed or required the fund to remain solvent and healthy, allowed the governor to non-charge employers that are paying out these unemployment benefits. We are still looking at that so that we can make sure that when that executive order is signed, that we have it nailed down sufficiently with a time frame that it doesn't affect the fund negatively, and that we are going to be benefiting employers in doing that. So that's still a work in progress, but I wanted to make sure that you didn't forget about that option that was passed in the special session.
Representative Hallinan.
Thank you, Madam Chairman. Director Cooley, the $300 benefit on top of the unemployment benefit that President Trump has discussed called for $100 to be added by the state. Now, is that $100 available out of CARES Fund, or is that something that the state is going to have to come up with?
Madam Co-Chair. Representative Hallinan, it's the $400 program that you would be allowed to use CARES Act fund for, or other state funds. If going with the $300 program, what it is all other UI benefits that are provided can make up that match, that 25% match. So in other words, state unemployment benefits, if you're getting PUA benefits, there's a whole list of the other types of benefits that you can receive that will actually make up that 25% required match. So that will not, we think that what we're paying out now will meet that 25% match out of hand without anything additional. So we think going with the $300 per month match, we're already where we need to be in order to do that.
Representative Sweeney, did you have a follow-up?
Yes, thank you, Madam Chairman. So, Director, I'm still concerned that I just somehow, some way we need to figure out so the employers aren't held responsible this next year through no fault of their own, and especially those that were ordered to be closed. I just can't see how that's fair. So I'm hopeful that that the governor will act on that and take care of that. The other, I guess, concern is again on the experience rating. I just want to make sure, and if we need to do something, not in the special session, but the general session, I hope somebody comes to either this committee or another committee so that our employers aren't penalized for no fault of their own. And then does the governor have the ability to put, I know other states have put a lot of money, $500 million plus into their workmen's unemployment funds out of the CARES Act money. So do we have the ability, because not 100% of these funds have been allocated yet by the governor's office. So does the governor have the ability to put another $25 million into the unemployment fund?
Madam Co-Chair.
Director Cooley. Sorry, I was pulling out my special session bill here. Go ahead.
Representative Sweeney, there is always that option to put additional funding in there. But I want to remind, and we're keeping a very close eye on it. We've got some other individuals that we're working with in order to nail down some of the very questions that you're asking right now, because it's very uncomfortable to not know. But when you're working with factors like are in the statute, it is very difficult to know, but we're trying to get it nailed down as much as we can. But to answer your last question, absolutely yes, there is an opportunity, always an opportunity to put additional funds back into the UI Trust Fund. Please remember though, we went into this COVID situation with, depending on which reporting service you looked at, either the first or the third best, most healthiest UI Trust Fund in the nation. Other states are already working with DOL to get loans to pay some of their UI funding out there, and we're just not in that situation, thankfully. So our trust fund is healthy, but we are looking at it to try to determine as best we can what the tax increases may be to employers in the 22-23 timeframe. Next year, I'm not sure we'll see it. Where I think what it would happen is 21 or 22-23 timeframe.
More questions for Director Cooley? Okay, I think those were your parts. Is the rest under Mr. Wolf's presentation, or do you want to talk more on either of those other things?
No, thank you, Madam Co-Chair. It's I'll send it over to Administrator Wolf.
Thanks so much.
Thank you, Director.
Mr. Wolf.
Thank you, Madam Co-Chair, Mr. Co-Chair, members of the committee, Jason Wolf, Administrator for Workforce Standards. I oversee the Workers' Compensation Program for Wyoming. All of you should have been handed out in your materials a sheet titled Workers' Compensation Summary. Hopefully you all have that, have had a chance to kind of look at that. If it is okay with the committee, Madam Co-Chair, I have prepared just a brief presentation that I think will help kind of guide our discussion. And I know that kind of the crux of the discussion is going to center around, the coverage piece of workers' compensation, in particular, what employers are required coverage and what employers are considered optional coverage. So if you wouldn't mind, just kind of like to share my screen and go through this presentation. I think just give a brief overview, really broad of our workers' compensation system. Hopefully that will spur some questions for you all and maybe answer some questions as we go through.
All right.
Now, let's see. Can you see that?
We can.
Okay, so you're seeing the presentation. Okay, and you can hear me okay? Sorry.
I can.
Okay. All right, so we'll just briefly begin on this presentation again, just to cover Wyoming workers' compensation and its kind of core function, what we do basically. So just a real broad overview, of course, workers' compensation is 100% funded by employer paid premiums. I think most of you are familiar with, the basics of workers' compensation. Wyoming is one of 4 states of what we call kind of exclusive state funds. That means the state actually runs those funds as opposed to allowing private insurance to sell those other work comp policies. So Wyoming, North Dakota, Washington, and Ohio are the 4 exclusive state funds. So what workers' comp does, of course, is cover injuries that occur on the job. And in exchange for those employers purchasing a policy through Wyoming workers' comp, they in exchange get what we call the exclusive remedy, or which means that they are protected from lawsuits from the injured party. So it is worth noting that those employers in the state that may opt out of our coverage because they're not required by a certain code do not have the benefit of this exclusive remedy. Kind of what kicks off the process is anytime an employer comes to do business in the state, they should be registering with both work comp and unemployment. From that registration process, we go through a analysis of the business, what they do. We determine what's called a NAICS code, which stands for North American Industrial Classification System. Pursuant to that NAICS code, then we follow the statute outlined there in 2714-108 to determine if they're required coverage or if they fall under a class code that is in fact optional, meaning they do not have to purchase coverage. Just for your benefit, all of the workers' compensation statutes fall under 2714-101 through 2715-103. And that is what we refer to often as the Act. So, and we can certainly share this presentation with you if that is your pleasure. So just let us know after the meeting. So workers' compensation really consists of 5 basic functions, basically. So we have a claims section, which we'll go through each of these individually just very briefly. We have an employer services section and a provider services section. We have a safety and risk department, which are consultative people. And then we have a risk management unit, which again, both the safety and risk and the risk management are really proactive measures that are available to any premium paying employer at no charge, no additional charge, because they're already paying for it through premium. So, so first off, we have the claims section. So the claims section really is this process is initiated by a report of injury. So something happens to somebody at work that initiates a process. They and the injured party and the employer usually complete our injury report form that is then sent in to us, and it gets assigned by whoever has that employer to a claims analyst, and then they review that for compensability. That means, is it covered under our statute? Does it meet the definition? I'm sorry, did somebody say something?
I think make sure your mics are muted if you're doing other things. Go ahead.
Okay. So this group of claims analysts, they work with the injured party to, schedule appointments, get them to treatment that they may need. They analyze the bills that come in for, again, are they related to the work injury? Is it our responsibility to pay this bill? And then those move through a process to get paid. Within the claims section, we also have a group of registered nurses that are available to both assist the claims analyst in, again, kind of that review of the medical documentation and the bill. Sometimes not surprising that we get some things that may not be considered related, and then that has to go through using the statutory mechanisms available to us. We have to determine if that is truly our responsibility. The nurse managers, they also pre-authorize surgical procedures. They're responsible for helping assist the injured party. Excuse me. They're available to help assist the injured party to purchase things like durable medical equipment. That might be crutches or prosthetics or other type of equipment that their injury might require them to use. They also monitor medications and make sure that those medications that they're on are, again, reasonable and related to the injury per the Act. The other second section here is employer services and provider services. And so really this employer services section is really the section that does the bulk of the work that we want to talk about today probably, and that is the coverage section. So sometimes we refer to this as the policy section or the tax section, but employer services is really the unit that handles this work. And so when an employer comes into the state to do business, they register with workers' compensation. We review that again to kind of go through the process, make sure that they are required coverage, optional coverage. They're the unit that is responsible for collecting premiums. This is where employers file their quarterly and monthly payroll reports. We issue those certificates of good standing. If an employer is doing business, they're bidding a job, oftentimes the general contractor wants something that says, hey, are you good in good standing? So we issue a certificate saying, yep, they're paid up on their workers' comp. And we also handle multiple phone calls from out-of-state employers who might be coming into the state. I think from several sessions ago, many of you are familiar with the extraterritorial coverage and how that kind of works, but oftentimes we'll have employers from Montana or Colorado come in. Again, these are people who may not have to purchase our coverage depending on their classification and whether or not they're hiring Wyoming employees. So that's all the determinations that will go through this unit when we get that registration. And then a big part of what this unit does is we set the employer rates. And so this is a big process. It's probably the biggest process of what they have to do aside from taking those registrations and stuff. This is a multi-month process by which we consult with our actuary. We feed that actuary data from our claims system, our payments, our investments of the fund, and that whole process, we end up coming to what the employer's rate per classification will be. And so, for instance, we're kind of finishing up the rates coming up for 2021 that will begin in January of 2021. And we, I think, as you guys know, by statute, we report to the Labor Committee that actuarial report. I think it's due every November 1st. So we'll have that report to you guys coming up, where you guys get to see what the actuarial soundness of the fund is, what the coming rates are going to be, et cetera. Any questions so far?
I will bring something up, but I'll just wait until the end, so
okay.
I won't come in the middle.
Yep. Thank you, Madam Chairman. So premiums, workers' compensation premiums, and again, kind of important to note, I know you guys have data thrown at you all day, and so these are the workers' comp fund and the unemployment insurance fund are two completely separate funds, two completely separate rates. I think all of you know that, but it's kind of bears some reiteration every once in a while. So the premiums on the workers' compensation side really are a combination of what we call a base rate. So XYZ employer might be a roofer, comes in, they're assigned a base rate based on that roofing classification. Then if they have an experience rating, which that's all set in statute, we have to have they have to be doing business in the state. We prefer a 3-year, statute says 3-year or as much thereof. So they can actually get a experience modification rating with like a year of business in the state. So again, the EMR, what we refer to it as an EMR, experience modification rating. That adjusts the base rate for an employer up or down, depending on their experience. So, if an employer has a lot of slips and falls, they have a lot of costs that we've paid out, chances are they're going to have a high, what we call a high EMR. And so it'll adjust their cost that they pay in premium up or down based on that experience. And then our workers' compensation safety and risk section. Some of you may recall this was a section created, I think about a 2017 session. We opted to pull out some OSHA consultants from the OSHA program based on some funding issues with the feds. We then placed them under the workers' compensation section. It removed some of the onerous federal regulations and stuff that they were having to follow. And anyway, these people are consultants. They are invited in. These people do not just show up on site. Employers invite these consultants into their business to review their business practices, policies, et cetera, and help them identify and get rid of hazards that might be on the job. This is a real preventative way for employers to curb injuries, and we have quite a few employers who take advantage of this. Again, these people aren't punitive. They won't come on site and give any citations. These people are purely consultants, and they come on and are there to basically assist the employer and see how we can help them curb injuries and ultimately lower and reduce their premiums. So we also have a risk management section. We do have 3 certified risk managers. These folks, they get into a little bit more of the detail that the consultants. So the risk managers, when they're called up and invited to an employer, these people dig in deep on what their EMR is, what is their injury trends, what are their safety policies, all those sorts of things to, again, help the employer prevent injuries and help get them, if they have a high EMR, help them lower that down. If they have a good EMR, it's to help them keep it that way and lower it even further. So this group also administers all the employer discount programs that we have by statute and rule. Again, these programs are highly encouraged when we show up on site, invited to these businesses, and an employer, if they enrolled in all these programs, can reduce their premiums up to 30%. So it's nothing little. 30% of some of these premiums can be awfully high. So, and then what is an employer? In statute, we have, of course, the definitions that apply. And both employer and employee are defined in there. And so an employer, per Wyoming definition, is any person or entity employing an employee engaged in extra hazardous occupation or electing coverage. So again, this I think is, as you probably know, all states' workers' compensations differ somewhat. In general, there is, most people are mandated to have coverage. Wyoming is a bit unique in that we have kind of what's referred to in the industry as an opt-out provision. And not many states have that opt-out provision as we do. And we'll get into that, I think, a little bit more here shortly. So who is required to carry workers' compensation coverage? I kind of wanted to just maybe provide a few examples here and maybe spur some conversation. So required employer is any employees performing work in hazardous sectors or subsectors or industries defined under that statute 108. Some of that, what you would probably think of, your welders, your construction workers, most of that, and then some of them you probably wouldn't think of. Optional coverage is any employee performing work that is not enumerated under 2714-108. So some examples of, take agriculture, sector 11, and so required under that sector would be forestry and logging. Optional under that sector is agriculture and animal production or crop production. And it's worth noting that almost all states, if you look at their laws, typically have some kind of exemption in them for agriculture type businesses, family-owned farms, ranches, etc. I'm not aware of any state that doesn't. So, and this, I think, is probably where we'll end up focusing a lot of the conversation on here after the presentation, probably. But some retail examples of required versus optional. I would just note before that most retail establishments are not required under Wyoming statute. Right or wrong, that's just the way it is. And that's the way it's always been since I've been here. So But some required examples would be like warehouses, gas stations, auto parts stores. Optional coverage under the statute as it's currently written is grocery stores and super centers. I think you'll probably hear some public comment later on some of the other stuff regarding warehouses, retail, etc. I'm happy to answer any questions there. I have had some conversations with labor unions and whatnot, and so again, I think they're fairly aware of what's required and what's not required under current statute. This is often a topic of conversation. School districts, again, under the current statute are not required to have coverage. Falls under what we NAICS code, educational services. Per the current statute, what it specifies is that governmental entities engaged in or employed under certain parameters must maintain coverage. So what that kind of equates to is if you have some examples I gave down there are custodial staff, maintenance workers, ground crews, and some teachers. And some of the teachers, the way the law reads is that if they would otherwise be covered in a other industry. So if you have a science teacher who does lab work, for example, that would be somebody who's probably required under the statute. If they worked in a pharmaceutical lab or whatever, they would be covered. And so would a science teacher. So would your shop teacher, home ec teacher, anybody who's engaged in what you would consider otherwise extra hazardous outside of that school district, they would be required to be covered. And so just some statistics here that I think, so what we show in our system as of June 30, and this is what we show in our workers' comp system, excuse me, this is how many employees are being reported currently as of June 30th of this year's 282,417 employees. We should have titled this employer, but so those employers that are required coverage, we have currently, again, all these statistics are as of June 30. We have 11,392 employers in the system that are required. And we have 5,342 employers that are optional. And so you can see the annual premium that's generated from those, roughly about $212 million annually in premium between those two required and optional coverage. One question that I think, Madam Chairman, you may have asked earlier via email was, the total registrations or the total policies that come in that are optional coverage that don't buy coverage through us. And so that's what that corner number there is, the 1,134. We had, and this is for calendar year 19, we had that many employers, 1,134 employers register with us. We determined them to be optional, and so they didn't purchase coverage with us. And then just for knowledge, I threw some state comparators in here. And again, these are the other three exclusive state funds. So North Dakota, what their law is very, a little bit different. Again, there's some exclusions in there, and but they do require basically every business that's doing business in the state to purchase coverage through them. They do not allow private insurance, as none of these do allow private insurance to cover them, with the exception of Ohio, I guess. Washington, again, pretty restrictive. They don't allow any outside coverage to be sold. You must maintain coverage through them if you're doing business in the state. And then Ohio, again, probably, I often use Ohio as a comparator to us. They are very similar in coverage and in laws, just about 10 times our size. So but they do, basically, if you're doing business in the state, you have to purchase coverage through them. There is, they do allow a self-insured option. Self-insurance is a privilege, and you have to meet by their statutes, you have to meet some certain financial health of the business has to be maintained in order for you to carry that risk. So, and that is really all. So, what questions may I answer, Madam Chairman?
Well, I'll let other people go first. Questions for Mr. Wolf? I can't see your hand, so stick up your little blue hand. Senator Scott. You're still muted.
Thank you. Yeah, thank you, Madam Chairman. I would say I can't figure out how the system allows for the blue hand. My question relates to the optional coverage and the ones that don't get it. As I read the Constitution, to get the liability protection, you have to join the system. An employer who's optional, who opts not to have the coverage, doesn't have any immunity protection. And if we wanted to change that, we'd have to amend the Constitution, and that's a very sensitive section we haven't had much success with. Do you know how many, the questions are twofold. Do you know how many employers or employees are involved in that 1,100 employers who have opted out? And do you know, have there been any lawsuits against them over workplace injuries?
Madam Chairman?
Mr. Wolf.
Co-Chairman Scott. So a little, what I can tell you is in that handout that I provided that's titled Workers' Compensation Summary, it's a little difficult to nail down how many employees that really is, but what I can tell you is with that number that we have here, the 282,417 covered employees, about the best guess that we can provide you is the Bureau of Labor Statistics puts the Wyoming workforce, again, ending June 30 of 2020 at 296,430. So if you subtract the total covered employees, that gives you roughly about 14,000 employees in Wyoming that probably don't have Wyoming coverage. And as to the second part of your question, Chairman Scott, the lawsuits on, was it lawsuits on not being covered? Was that what I heard?
Yeah, lawsuit, Madam Chairman, if I may, lawsuits against employers who are not covered by workers who are not covered for workplace injuries. Do we have any knowledge if have there been any from that small number?
Madam Chairman, Co-Chairman Scott, yes, I do believe in the annotated statutes, there's some references to cases in there where employers have been sued because they don't maintain Wyoming coverage. One of those in particular kind of set the tone for warehouses versus retail workers. And I mean, we can spend a lot of time talking on that. There's a Supreme Court precedent out there that kind of has set the tone for what supercenters versus warehouses have to have coverage. And what it kind of boils down to is what the courts have basically said is it doesn't matter so much what your individual job is, if that's extra hazardous. The primary business of that employer in the state is what drives their code, whether that's required or optional.
Representative Roscoe.
Thank you, Madam Chairman. Josh, can you tell me how workers' comp handles non-resident employees? And there's sort of two parts to this question: how they would handle the green card worker arrangement with their employees, or I know as an employer, you go through, you find out, you get documentation that they are citizens. And do you check that at all when a claim is filed? Thank you, Madam Chairman.
Mr. Wolf.
Representative Roscoe, yeah, that I think about a year ago there was a story on Wyoming Public Radio, I think, that did a pretty extensive piece on this. But yeah, to answer your question, I think again, there's what we call a definition of an employee in the statute, and that really does set out a U.S. citizen or someone who is authorized by the Department of Justice to work in the U.S. And excuse me. So what, again, kind of what happens on our end when somebody with like an I-95, what's otherwise known as a green card probably, would submit to us that the employer usually submits that documentation. And again, this falls to as long as the employer reasonably believes that they hired this person as they were authorized to work in the U.S., then we would cover that claim if they filed an injury report with us.
More questions for Mr. Wolf. Chairman Scott.
Yes, and it's really in this area of outside firms coming in and whether they register or not. For employers who are bringing all their employees from out of state, are covered by some other state, are they at risk for lawsuits in Wyoming because they're not in the Wyoming program? Or are there arrangements between the states where they're covered by their own home state and they're under their own home state's law? How does that work out?
Madam Chairman,
and I have a follow-up to that one.
Okay. Madam Chairman, Co-Chairman Scott. So yeah, there's what we call extraterritorial provisions in the statutes, and that does allow for a business to come in, say, from Colorado, as long as they're bringing only Colorado employees, and say that's a roofing outfit. I'm not picking on roofers, I just have to use them as an example, but if they come into Colorado come into Wyoming to do business from Colorado, as long as they're bringing their employees and not hiring any Wyoming employees, then they don't have to maintain our coverage so long as they bring us proof from that state that they have coverage. And likewise, most other states will let our businesses go into another state, take our Wyoming folks to that state, do business. As long as you show them you have coverage through Wyoming workers' comp, you're still covered for that liability.
Did you have a follow-up?
Yeah, my follow-up is in that area, is there an incentive in the way that system works that keeps, say, out-of-state contractors that come in, things like that, from hiring Wyoming employees?
Chairman Scott, not that I'm aware of. In fact, I don't have any statistics in front of me, but I would say that a fair amount of employers from out of state that come into our state end up hiring Wyoming employees. And again, I don't have that figure before me, but that's just kind of what I know from years of experience and watching it.
Okay, so Madam Chairman, what I was really fishing for was, do we have any need to change the laws here because it's keeping Wyoming people from getting jobs? And what I hear you saying is it's easy enough for them to get Wyoming coverage for those people that's what they do, and it doesn't inhibit them from hiring Wyoming employees. Is that right?
Madam Chairman, Mr. Co-Chairman, yeah, I would say that's accurate. I think one thing that bears some discussion perhaps is when we do have, you know, again, I'll use retail as an example. When you have some retail outfits that are not required to purchase coverage through us, they may what's termed as self-insurance. So a big box store, for example, may be able to come into the state. They're not a required NAICS code, so they don't have to have our coverage. It doesn't mean that they necessarily don't have workers' comp for their employees. I'm sure they do. Wyoming has no statute to enforce how they pay those, and we don't have the staff to monitor that. By contrast, a state like Ohio, when a big box store goes into that state, they can self-insure if they meet the financial requirements, and they have the ability to retain that risk. How Ohio differs from us is that they mandate that those businesses pay per the Ohio Act. So you have to pay benefits in accordance with the, you know, with the Ohio law, et cetera. That's where Wyoming differs. We don't, as long as you're optional coverage, you can go on about your way if you have your self-insurance, and you know, we don't have any authority to enforce that, if that answers your question.
Yeah, Madam Chairman, let me try to get at what I was trying to get at earlier. With these employers who are optional, who have not gotten Wyoming coverage, do we know of any cases where an employee has turned around and sued their employer for a workplace injury, something that would be forbidden under the exclusive remedy, but you're an exception to the exclusive remedy? Have any resorted to that old suing system?
Madam Chairman, Chairman Scott, you know, I'm sure that there have been, but I'm not aware of any personally that I could point out. So, you know, to answer your question, no, I'm not aware of any that have sued their employer, and we wouldn't necessarily hear about that through our outfit.
I did actually discuss some of these issues with a local attorney, and he told me that he, in fact, had been successful in suing one of these employers who was self-insured. Which leads me into, so I see no hands up right now, so I'm going to launch into my little inquiry. The first is, in our special session, House Bill 1002, that had all the workers' comp and unemployment amendments. So when during special session, we added contraction of COVID to be considered an injury for the purposes of this act. But where that definition of injury is in Title 2714 and so on. So my first question is, that application of COVID to be a workers' comp covered situation, because it's in the workers' comp law, does that only apply to employees who are working for an employer who is covered under the state plan?
Madam Chairman, yes, it would only apply to those people who have the coverage under the act.
So people who are working for a retail, a big box, or some other group that are self-insured, what we attempted to do through that bill will not apply to those employees, 14,000 employees, right?
Madam Chairman, that is correct.
Okay, so then the second thing, and this is just for committee's consideration, and this might be a big lift. I'm not really sure where to go with this, but so over the last couple of months, I have been hearing from a person in my community who wrote to me because he works for one of these big companies who is self-insured, and he was injured on the job. And of course, I'm only hearing from him. Okay, I'm not saying who's right or wrong or any such thing. I'm just explaining situation. He was injured on the job. He had some surgery. The surgery didn't go as he expected. He couldn't go back to work. The employer said, well, if you're not back by such and such a date, then you're going to lose your job. And he's worried about losing his job, and he's worried about losing insurance, and he can't seem to get the doctor to follow up. Anyway, it's the kind of thing that people contact legislators for, right? I mean, and you're like, I don't know what to do for you. So the problem that I kind of see is that I feel like through all the years that I've been on Labor Committee, when we would hear presentations from the workers' comp folks and Mr. Wolf's predecessor and all, is that in effect there is a sort of a mediating capability that the state has between employer and employee by virtue of being involved in the insurance component. That when there are, and back earlier on in Mr. Wolf's presentation on the claims, you know, there was the case management, the discussion with the providers, all that kind of thing. And really, after this poor fellow, he and his wife, I think, called me twice and emailed me 4 times. And to be honest, and I, as a former healthcare administrator, I never like to say this, but what I felt like saying was, what you need is a lawyer. But because it's a very large employer, he really can't find a lawyer who wants to take on a large business. I talked to legal aid. Legal aid doesn't do workers' comp cases. I talked to the UW Legal Clinic. They don't do workers' comp claims. And so one of the reasons why I put this topic on here, in addition to just following up on the workers' comp rape holiday that Management Council added to us, is it, from a worker perspective, I feel like I wish that there would be a way that we could at least require some sort of mediation ability in there between the worker and the employer in situations where the employer is self-insured. So that's why I brought this up. I'm not sure how to work that into statute. If people have ideas, I would be glad to take them. But I feel like that is a gap, probably an unintended gap. And certainly I'm generally very employer friendly, but you know, when people work for large national companies, as a little guy who's making, you know, $14 an hour or something, it's pretty tough to make any headway if your employer says, too bad for you, which, and maybe that's not really what they said. I mean, I'm just going off of this, but whether this person that was contacting me has a problem or not really, you can see that there might be a problem for some people. So I'm just expressing my thought here. I don't know if people have any concerns or thoughts to contribute. Chairman Scott.
Madam Chairman, what you've outlined is the classic example of why the workers' compensation system was created to start with, because under the old, the optional ones that don't have the Wyoming workers' compensation coverage, they're under the old system where you had to get anything, you had to sue the employer and prove it was the employer's fault. And particularly with some of the larger companies that could afford to fight you tooth and nails with lawyers, the worker tended to wind up with nothing. The remedy for that situation is to, I think, require some of these optional people, require more of them to get into the system, because it's designed to deal with just the circumstance that you're talking about. For many of the smaller employers, they get in because they know they can't afford to fight a lawsuit. Some of the larger ones may take the opposite point of view and be able to. and then your workers wind up exactly as your constituent was, just being left out and cold after one of these things. So I think the real remedy is to keep the optional levels down as much as we possibly can, because the current system, if an employer is in an optional one, is an invitation to just the kind of trouble you had. And the way to get it is get them onto the Wyoming system.
Any more input on this? Because it seems to me that as Chairman Scott said, that's certainly an option, is to basically either remove the opt-out provision, which is a pretty big sledgehammer. Another possibility would be in some way to mandate some sort of mediation, at least. I mean, I don't know. Well, who else has got something? Anybody else? Some of you employers out there may have thoughts. Representative Sweeney. Representative Sweeney, did you have your hand raised? Okay.
Yeah. Sorry, Madam Chairman. So are any of the energy companies allowed to opt out?
Mr. Wolf, are you?
Madam Chairman, I think energy companies it depends on the job classification, I guess. I would say, if you think of an energy company in the traditional sense, I would say no, they're probably required, just based on the hazardous nature of the work.
Okay. And so the big box operators that there's one major retailer that has about 12 super centers, which most of them contain, I think they all contain a grocery store component to them. Are those the type of retailers plus the major national chain grocery stores we have in our state, have all of those opted out?
Madam Chairman?
Mr. Wolf.
Representative Sweeney. So I think just to kind of follow up on that number that I gave you of again, I only pulled 2019 data just so it doesn't get too confusing, but of those 1,134 employers in 2019 that opted out of coverage, it looks like the bulk of those are what we call professional services. And so let me just give you a few examples of those, what kind of that includes. And so that's roughly out of the 1,134, 821 of them fell into these categories. So real estate, finance and insurance, professional services to include legal services, accounting, tax, architect, engineering, computer system design, research. And then it looked like we had a total of some kind of retail, maybe not necessarily a grocery store, but it could have been a bookstore, a health food store, or some type of retail outlet. 152 of those were retail. Another big faction that is not covered is educational services. So those, I would say, are your three main areas that don't opt in for coverage.
Representative Hallinan.
Thank you, Madam Chairman. I think that the individual that you described is the kind of person that our lawyer colleagues say that they have contingency fees for. And I would think that a good attorney would be able to take this case and make some money for the injured party and also for himself. So I don't really know that we need to have any other remedy other than that. Thank you, Madam Chairman.
Chairman Scott.
Madam Chairman, on arbitration, look at Wyoming Constitution, Article 19, Section 8, and there's some restrictions on what we can do there.
Well, and not looking that up right now, but I know that we can't restrict people's access to the courts. But it seems to me that you could require people to offer an, I'm not sure. Can we not require them to offer that option?
Madam Chairman, I think it has to be voluntary.
Well, how does that work in with a workers' comp system then? Aren't you restricting everybody's access to the courts?
That's a very explicit provision of the Constitution. And it's not strictly speaking arbitrary. It's an exclusive remedy, and it is really set forth when you read Article 10, Section 4. It is really set forth as an exception to the general rule. And a very clear one.
So in other words, the removal of opt-out provisions would be constitutionally more available than a mediation introduction.
It would, Madam Chairman, on quick reading, that would appear to be so. That the remedy under the Constitution is to require the coverage. And whether or not there's enough of a problem to where we really ought to do that, that's something the committee can discuss over time.
I'll just answer to Representative Hallinan. You know, as we go on, obviously I don't have an answer for this right now. You know, knowing how long lawsuits can drag out and the difficulty of a lower income type person in successfully attracting an attorney's interest and being able to carry out a year or two long lawsuit is certainly a discouragement to anyone who feels like they have a problem that they need fixed, and whether they're able to continue working while they're hoping the lawyer will succeed. I mean, I am not a big fan of lawsuits at all, but anyway, I don't see any other hands right at the moment. I just wanted to bring this up for an issue. And again, as I say, noticing that what we attempted to do regarding COVID is obviously doesn't apply to anybody who works in these retail situations, grocery situations, education services. And Mr. Wolf, did I understand early on in the presentation that if it's a government worker, unless they would fall under workers' comp? So let me just be blunt. Are the school district teachers covered under workers' comp if they get COVID next fall?
Madam Chairman,
under our new bill?
It would depend. So if the school district or the schools opt in, if they have coverage and a teacher gets it who is covered under workers' comp, so those what that law says is if they would otherwise be covered in the private industry, say, so take a science teacher or a shop teacher, home ec teacher, those folks would be covered, but that's because they're covered by statute. They have to have coverage. Other teachers, like a math teacher, an English teacher, somebody who is not otherwise covered outside of the school district, unfortunately wouldn't be covered.
So just keep that in mind, folks. If you come up with ideas, you can send me emails. I mean, I feel like there's probably a lot more to the whole story of putting in the opt-out provision. I'm a little hesitant to plunge into that without further information. But I will continue contemplating this. And I do see Representative Roscoe has his hand up.
Thank you, Madam Chairman. I can't help you out with your situation, but I would like to ask Josh how the workers' comp figures a death payment. Thank you, Mr.
I'm not sure Mr. Wolf has sufficient time to explain all that, but give it a stab, Mr. Wolf.
Yeah, thank you, Madam Chairman. Representative Roscoe, you're testing my skills today. It is defined in statute. I think it's 2714-408, if I'm not mistaken. It is based, it's a 80-month payment, I believe, and it has to do with their age at time of death, also their education, etc. It takes into account several different factors. We calculate that award pursuant to the statutory mechanism. That is then paid out to the survivor, a surviving spouse or surviving children. Sorry, I don't have the exact answer, but it is spelled out in statute.
Okay, Representative Sweeney.
Thank you, Madam Chairman. With the downturn in the energy market in particular, and so you don't have those higher paying jobs paying into the workman's comp fund, how are the finances of the workman's comp fund currently and the trust fund?
Madam Chairman?
Mr. Wolf, and I think that actually that leads in as you're getting prepared. We do have on here follow-up on the workers' comp rate holiday from Senate File 89. I don't think we heard that. We heard about unemployment insurance fund, but I don't believe we heard about the rate holiday fund. So if I'm right, then you can merge those answers in.
Sure. Yes, thank you, Madam Chairman. Get my documents situated here. So, Madam Chairman, I forgot who asked that question. Was it
Representative Sweeney?
Sweeney. Yeah, Representative Sweeney. I think it's a little early for us to tell, what the effect of the energy downturn is on the workers' comp fund. I would tell you that actually, like I said at the beginning of this, we're in the midst of setting the 2021 rates. That involves the actuary study and, the claims data, the investment data of the fund. We did just, the rate of return on the fund, just FYI, for last fiscal year ending June 30 and the year prior, both were record-setting years as far as the investment return. The gross rate of return on the fund was 9.12%. Less fees, it's 8.97%. And last year it was about 8.47% rate of return. So I would say currently the fund is doing very well investment-wise. I think during this COVID period, I would say March, April, May, we did see a downturn in claims as well. And those are starting to tick back up, of course, as businesses reopened and got back to work. We started seeing more and more of those, but I don't know what the effect, to answer your question, will be on the energy downturn. I would assume, yes, there's going to be less, perhaps less money coming into the fund, but I don't know exactly what the effect will be.
Mr. Wolf, do you have any, my recollection is that the rate holiday bill didn't take effect until just now or recently. Do you have any report on how things are coming along with that?
Yes, Madam Chairman. So to kind of get into that rate holiday discussion, you're right that those, both the Senate File 89 and Senate File 1002, the budget session bill is Senate File 89 and the special session is 1002. Both of those provided for a premium credit. Per consulting with our actuary, you may remember he felt the solvency of the fund could handle what we gave ultimately was a 16.66% credit. So each one of those credits was 8.33%. That each credit is roughly 1 month of premium. And so, you know, in 1 month, whatever we bring in premium, that money is given back to the employers. So, I'm sorry, I forgot the last part of your question.
Well, just Management Council asked us to keep track of that bill and how it's going along. So I think it's just starting. So we probably don't know how it's going along.
Yeah, so they became effective July 1st. And because employers typically file quarterly, they won't apply for those credits until the end of the third quarter here.
Okay.
Some of the monthly filers, and I didn't find out, it's not many, I'll tell you that, but I didn't find out an exact number. We do have some people that file monthly, but it's a real low number that have applied for the credit so far. So, but all those employers were mailed, you know, the letter telling them what their credits were, what they qualified for. And so people will be applying for that here shortly. So
great. Okay. Any last questions for Mr. Wolf before I go to public comment on workforce services? All right, Elizabeth, have we got, I see someone's in the waiting room.
Yes, ma'am. We have Tammy Johnson here to testify on this issue.
All right, send her in. Oh. Ms. Johnson. You're muted still, but otherwise we can see you. Down in the lower left corner of your screen, if you hover around there with your mouse, you should generate yourself a little mute thing that with a line on it, and click it and it will take the line off.
Got it.
There you go. All right.
Yeah, it jumped away from me. So thank you, Madam Chair and members of the committee. My name is Tammy Johnson, and I'm the Executive Director for AFL-CIO Wyoming. It's great to see everyone. I just staggered out of the woods up by Yellowstone to jump on this committee meeting, so I'm not looking as professional as all of you, but I would like to share with you.
Tell through a Zoom screen, so you could, you didn't have to tell us.
Glad to hear that. I'm feeling grubby, but so I've worked with Mr. Wolf and Director Cooley on this topic for quite some time. And as you know, I represent, the constituents I represent deal with most of the workers in the state. And it came to my attention early on that grocery store workers, particularly who are essential, as well as other retail workers, were not included in the presumption for COVID. So as you've discussed today, if someone from a grocery store or a retail store gets COVID, but still has to go to work, what's the incentive for them to stay home and keep from spreading COVID? They don't have the resources to, they likely don't have the health coverage because most of those positions are part-time positions, not benefited positions. And then most of them, they don't have workers' comp, so they don't have a way to recoup their salary beyond the FFCRA if that were to apply. So it's pretty difficult to make sure that we're not going to continue the spread of the virus through our essential workers if they don't have the opportunity to stay home, continue to earn their wage. They can't collect unemployment if work is available. So it's really kind of tough. So we don't have a system that really addressed the situation we're facing with COVID. When we talk about public school teachers, as you know, I have been involved in education for quite a while as well. Public school teachers are probably not only the most likely to be exposed to the virus, but they're also dealing with a huge population to transmit the virus. So without a workers' comp coverage in place for teachers and educators, anyone who works in the schools, except for those who are covered, as Jason shared with you, We're also looking at a great potential for continued spread of the virus if they don't have the opportunity to stay home. Sometimes under the workers' comp, if you don't have workers' comp, teachers are required to use their own sick leave. As you know, many teachers don't have very much sick leave each year. They're already working in a germ pool to begin with, so you have to use that sick leave as you're teaching. So it's tough. We're putting these essential workers on the front line without the kind of coverage that they need. And I know you've discussed a lot of different options today as to what might be solutions, and I would love to continue to work with you on that now in the future. But for now, what I would like to ask is that the COVID-19 dollars that are available out of the $1.25 billion, that we can set some of that money aside to cover claims that come through that in order to protect those employees who are not protected with workers' comp. And Jason and I have talked about numbers and the numbers of claims that have already been made and those that were paid. And I don't know how you would measure how much money that might be, but I think that we can set aside some money that we could use if we needed to cover claims for those groups of employees who are not covered. The other issue, the bigger issue down the road of covering all employees so that everyone is treated the same to avoid the loss, the situation that you shared, Chairman Wilson. Those are not so few and far between. The conversations I've had with the commercial food workers in this state is that the self-insured entities rarely pay. They wear the employee down until they just go away, and it's more work for them to get the claim paid than it is to just go on. And hopefully in most of those situations, we're not talking about permanent disability or death, but we are talking about lost wages and medical expenses. If we think about this in the bigger picture, those employees need to be protected under the system as well. It's interesting when during the special session, when you made COVID a presumptive workplace injury, we excluded all the teachers. And I think there's about 17,000 education employees in the state, K-12. That doesn't include the University of Wyoming or the community colleges. So there's about 17,000 employees there. Now we know some of them are covered. We also heard from Mr. Wolf about the number of employees that are not covered through retail. And we know Walmart, one of the big box stores, is one of our largest employers in the state. So we know that there's a huge number of employees who are not covered through workers' compensation. And I think covering them with the COVID money would do two things. One, it would help stem the virus transmission. And two, it would provide a safety net for all those people who don't have coverage. Let's see, there were a couple of questions that were asked that I wanted to address. See, I wrote them down. I think it's I think if we address the issues surrounding COVID right now, and then we continue to look at this, I would love to be involved in these conversations and help us find the best route that protects both the workers and the employer, because that was the original premise behind workers' comp. It's sort of a quid pro quo. We'll take care of the workers, but the workers won't sue the employer. And we know how important it is to keep our businesses up and running. And we don't want to have, like you said, Chairwoman, we don't want to have devastating lawsuits and lawsuits that go on and on, but we do want to have a healthy worker environment and healthy working families. So when we're thinking about who we're protecting and who we're taking care of, we're thinking about the Wyoming workers first, I hope. And I can answer any questions you may have, I hope. Thanks.
Chairman Scott.
Okay, Madam Chairman, the question for relating to the remedy she's proposing, the 1.25 billion we will probably not be in session again in time to do anything about that because that money has to be spent per federal law by December 30th of this year. And we won't be in session until then, and we can't set it aside to pay future things. It has to be spent. So my question for her is, how would her organization feel about an effort to include some of these optional employers as a extra hazardous, given our experience that we've had, and ensure that they do have workers coverage? I'm thinking particularly of the retail and the superstores category. Education has got some other complications, and it also tends to have pretty good health insurance. But how would she and her organization feel about an effort along those lines?
Ms. Johnson.
Madam Chair, Co-Chair Scott, we would love to see retail workers covered under workers' compensation. And, you know, I think you heard earlier, we're one of 4 states that don't require coverage of all employees. And it's kind of a question as to why. Maybe that's the way we've always done it, but we live in such a complex system now. And you'll have employees, as you know, in this retail sector, in the service sector, who work 2 or 3 different jobs. So having them covered under one system has to be a better solution than asking them to fend for themselves. So we'd be real supportive of that.
Any more questions for Ms. Johnson? Representative Sweeney.
Thank you, Madam Chairman. So, Ms. Johnson, do you, under your organization, do you also, on the teachers, do you speak for Wyoming Education Association? Is that part of the membership? And then of the different unionized workers, I'm trying to think how this might work. I like the idea, but would you be speaking for, or is it just the Wyoming Education Association?
Madam Chair, thank you. Representative Sweeney, I do not speak for Wyoming Education Association. I no longer am working for them. However, Wyoming State AFL-CIO feels an obligation to look out for all workers in Wyoming and to share and to try to pursue things that help all workers. We have a lot of categories of workers in the state who are not unionized and who don't belong to AFL-CIO, but we still care very much about workplace safety. We care very much about living wages. We care very much about taking care of working families and making sure that our state is a great place for working families to live and be successful. I think you would note that most of the, we have a lot of people in the mines and in the bigger industries where they do have a higher risk of injury. In Wyoming, our on-the-job death rate is 3 times the national average. And most of those workers are not unionized or members of AFL-CIO, but we still believe with all of our heart and advocate for workplace safety. So COVID-19 is just another example of workplace safety issue that we'd like to be involved in. As far as my own health, I mean, when we open schools, we're all at risk. And, teachers are going to be, those schools are going to be big vectors of illness. And I think the state can and should do what it can to protect all workers. And we have an opportunity here with the money from the feds that helps support us taking care of the virus. And by giving workers the out they need, if they need to get out of work, to not continue to spread the virus, not to take it home, not to infect, their elderly population and loved ones that they care for. I think we have an opportunity to do our part. And I know, Senator Scott, you said earlier that the legislature is not going to meet. So maybe it's not within the power of this committee to share that and have that money allocated for workers' comp. But I think there can be some conversations with the governor's office if he is going to distribute all that money, that it could go in this direction. And I'm happy to have that conversation with his office as well. But I hope that we can do it together and be on the same team, because we need to protect those workers.
More questions for Ms. Johnson? Oh, Representative Sweeney.
Thank you, Madam Chairman. And maybe this isn't for Ms. Johnson, but so in thinking through this, and I don't know how we could reach over as far as, say, grocery store workers as an example, but definitely school teachers, in thinking through this, and that aren't covered under workman's comp. Is there a way, and I think this would be to Mr. Wolf, with the CARES Act funding, say 10 million got set aside, or whatever the number that the executive branch would come up with, by executive order, could the, if we have such a thing, could the governor say, we're going to set aside, allocate 10 million over to workman's comp if we have school teachers that end up ill? Would that be possible utilizing workman's comp?
Mr. Wolf.
Madam Chairman, Representative Sweeney, so it's going to be a little, I think we were already allotted, like I said, the money for the second premium credit, which equates to about $16.5 million. Up to the governor's office if they chose to allocate further dollars to us for that cause. But yeah, I think it would, the people who aren't currently covered, we would somehow have to get them covered under the system in order for us to pay any charges, on that person. And that's not your problem necessarily. It's just a logistics of how do we pay for somebody in the system that doesn't have coverage. It's just a system thing that we'll have to get around should that be decided.
I might ask Mr. Brody or Mr. Shaw here. I mean, it just seems to me as a non-attorney that to spend money through a program for people who aren't covered under that program seems like a rather dubious legal leap to me. Any attorney input on that, or have they all gone out for dinner?
Madam Chairman,
you're here.
Indeed. I think it's a complicated issue. One issue that you do have is that the coverage that is currently provided is for those employers who do pay benefits. And to the extent you provide coverage for employees where the employer never paid a benefit, that is a substantial problem, because you're extending a benefit to 4 employees whose employers never bore that burden. I think that is a problem. And then as Mr. Wolf mentioned, just the logistics of providing payments to people who aren't otherwise registered in the system, would likely be problematic. But yeah, I think there are potentially legal issues there that we would have to try to tackle.
Yeah, it'd be easier actually to just route money through FQHCs or various clinics or something, hospitals, to pay for healthcare for uninsured people or something like that would probably work better. But anyway, we'll keep thinking on that. But do we have, let's see, I'm sorry, Ms. Johnson, did you have a comment?
Madam Chair, just one more comment. And Mr. Shaw, I appreciate those comments. I think there's a way to do it. And I think because it's COVID money and it's COVID specific, and by keeping people who are ill out of the workforce, we do exactly what that money was intended to do. This isn't about, it's not fair, I've paid in, they're not. It's how are we going to stop the spread of a health crisis? And so that's the angle that I'm looking at this from. Surely it's not the same if you've been paying in a premium, but now there's the premium holiday as well. So the people who are not paying into workers' comp are not getting covered, and the others are getting the premium holiday. So, I mean, I think it's 6 of one, half dozen of the other in some ways, but our intent is to stop the spread of COVID and to keep people home who are sick. And they're not going to, grocery store workers are not going to stay home if they can't get coverage because they need to eat and they need to pay their bills. They're still going to go to work.
Representative Roscoe.
Thank you, Madam Chairman. I was just thinking about the teachers, and maybe it could just be the money could go towards adding sick days or available sick days to them. Thank you.
And Representative Hallinan.
Thank you, Madam Chairman. I guess I have a question for Mr. Wolf. The companies or the school districts that have opted out of the workman's compensation program, can they opt in again? Can they opt their employees in at this point? And the second part of this question would be, what would be wrong with the governor, say, appropriating out of this COVID money that we have, 1.25 billion, a whole lot of it still available to the governor? What would be wrong with him reimbursing the school districts for that money that it would cost them to opt in for their students, for their teachers? Thank you, Madam Chairman.
Madam Chairman, Representative Hallinan, just to make sure I understood your first question was, can the teachers who aren't covered now opt into the system? Is that correct? So, Madam Chairman, yes, the answer to that is they can certainly opt in. You know, there are certain districts who in fact cover all their employees, others cover those that are just required. So, you know, again, that's kind of the difference around the state as to how people choose to cover their staff. I would also add, kind of back to Representative Wilson, your prior question, and maybe to Ian's point about, you know, what's the legal leap there? How could we get around that? To my knowledge, and again, this may be different through the state, but I believe that most of your teachers that are, you know, as Senator Scott alluded to, have the health insurance. Most of them have what's called a rider on their policy that covers them exclusively for workplace injuries. And so it covers them differently than their regular health insurance would. Again, I don't know that everybody has that, but that might be something, if funds were available, that you could look at dealing with those insurance companies versus making them come through the workers' comp system.
Representative Yin.
Thank you, Madam Chairman. So maybe this question is for both Mr. Wolf and or Ms. Johnson. So I know my employer had to make some changes to its leave policy based on the Families First Coronavirus Response Act, which required certain companies to have paid leave for COVID-related reasons. And I'm wondering how many of the companies that aren't covered by workers' comp fall under that act, and also whether our public school systems fall under that act as well.
Mr. Wolf.
Madam Chairman, Representative Yin, yes, and I think we had some discussion about that back in the special session, but the FFCRA, or the Families First Coronavirus Leave Act or Response Act, and I read it, but I have to go reread it. I believe it applied to those employers with under 500 employees, allowed for 80 hours of paid leave through those funds. But again, I'm not 100% sure. I'd have to go reread it.
And before I call on Senator Bouchard, who I did see his hand, but I just wanted to say, you know, the COVID discussion is great and worthwhile, and I brought it up myself. But you know, I don't think we should have the conversation be only about that, because if you have an employer who works for, or, you know, an employee, I mean, at a retail operation or a real estate place who is, you know, has a dumpster fall on them, or, I mean, I don't know what else, some other thing, you know, it's not only COVID. Senator Bouchard.
Thank you, Madam Chair. You know, we're doing a lot of talking about COVID. I want to know some numbers. I mean, have we had this big influx of grocery store workers that are coming forward in Wyoming, or I mean, or anywhere in the state? What kind of numbers do we have? Do we have claims for workman's comp that we can look at?
And so just let me follow on that. And so Senator Bouchard's questions are good. And that's why I said, you know, it shouldn't be only about COVID. I mean, people who work, the 14,000 employees across the state who work for a company that is self-insured and who may or may not have the wherewithal to beat their head against the employer's door if they've been injured. You know, I mean, we don't want to have, this isn't just a COVID discussion, I don't think. Go ahead, Mr. Wolf.
Yeah, thank you, Madam Chairman. Senator Bouchard, yeah, we do have, currently we have 138 claims filed for COVID under workers' compensation. It looks like to be 34 of those have tested positive. And so if you remember, Senate File 1002 allowed for, kept in place kind of the definition of injury, if you will, that they had to have a harmful change. And so we cover the ones that are positive test. If they're negative, they're still, you know, not technically a compensable claim. But I would tell you that to avoid litigation, we're probably paying for those tests on the back end.
Senator Bouchard.
Thank you, Madam Chair. Just follow up. So you had 138 claims, and out of that 34 tested positive, and what kind of time period are we talking there?
Madam Chairman, Senator Bouchard, that is since March 12th that we're looking at when COVID hit. So we've been tracking those claims since we first knew about it up to present day. So.
Okay, so this is, you know, obviously a subject that could go on for a very long time, and seeing as we don't have an answer today, I don't want to spend much more committee time on this, but I think the issue of workers' compensation for on-the-job injuries for people whose employers have opted out of the plan is something that should stay on our radar screen. Whether it's COVID or dumpsters or forklifts or mad dogs or whatever. And so let's just kind of keep thinking about this, you know, ponder the statutes, see what the situation might be, and we'll leave that rest for the moment because I don't think we have an immediate answer. There's general public comment is listed at the end of tomorrow. But Elizabeth, if there's anybody hanging around in the waiting room wanting to make a comment today, I hate to make them sit here for another, till tomorrow lunchtime. Is there anyone left?
No, ma'am, there's no one left in the waiting room.
Okay, then there is not. All right, then Chairman Scott, do you have anything to add before we recess for today?
No, Madam Chairman. It's
okay.
Time.
All right, I think we will pause here then, pick back up tomorrow at 8 a.m. We will have a morning's agenda of mental health topics, and my really desired plan is to be done by lunch. So all you long-winded colleagues, prepare your conciseness pills overnight. Okay, see you all at 8 in the morning. The meeting is in recess until tomorrow at 8.
Thank you.